All right, ladies and gentlemen, thank you very much. The hour of 2 o'clock having arrived, if we could ask the chambers to please come to order. And the first item of business is the call to order and to establish a quorum for the purposes of doing business.
Vice Chairperson Ellenberg. Chairperson Sermidian.
Here.
Thank you. You have a quorum.
Thank you. The presence of a quorum having been established, we have item number 2, public comment. And Supervisor Ellenberg, I'm informed that our overhead is not entirely functional today, so I will be calling these out with a little more specificity than I usually do, just so everybody knows what we're talking about and for the record. Public comment, of course, is item number 2. Looks to me like we have maybe 15 cards, so we're going to call everybody in order, but we are going to ask that you limit your remarks to 1 minute. 1 minute, please, so that we can get through all of the cards and give everybody the opportunity to speak and still make our way through the agenda. So let me ask folks to line up if they can so that we can move along expeditiously. We're going to begin with Leonard Williams, then go to Ingrid, I believe it's Guevara, and then Eva Renteria, and then Frank Vieira, and then Josiah, I believe it's Arellano, and then Edelmira Arellano, and then Deborah, forgive me, Basto, something. We'll get there, I promise. And then there are a number of others, but let's start with those. So, Leonard Williams, if you'd like to make your way up, thank you. Followed by, as I say, Ingrid Guevara, Eva Renteria, and those that I called.
Yeah, my name is Leonard Williams, and I'm with the Patient Family Advisory Team at East Valley, also representing all the clinics and the hospital as a PFAT ambassador. I want to say thank you for all the support you've given PFAT over the years. We just had a successful all-day seminar out at Center Road, Center Park, and we had a good brainstorming session. And I'm proud to announce that we now have 11 PFAT clinics around the Bay Area, and we're working harder and harder to get more members. Thanks to you and thanks to the work we're doing, I took on as a PFAT to get Ludlow Way, which is a city street, paved. It's finally paved after all these years. Thanks to all the hospital people that are helping us. We now have our building power washed and we're waiting for painting. So thanks again for all the support you give, and I hope you keep it up.
Great, thank you very much, sir. That takes us to Ingrid Guevara and Eva Renteria, in that order, please. And then Frank Vieira, come on up.
Good afternoon, my name is Ingrid Guevara. I come from Honduras. I'm going my citizenship now. And first one, I said, thank you, Mr. Smith, today. You make me breathe. And then I work in O'Connor 2001, and I'm the bill lead in EVS department, PM chief. I have very good coworker, hard workers. And then my husband worked there. He's in the kitchen. I have my older son. He's a CNA. And I have daughter, 26-year-old. She's a nurse. Then O'Connor, they give me a chance to working hard to keep me my house. I give it to my daughter, her master in nursing science. And I got my younger son, and I told my son, I think you have to leave the school. He wanna be a nurse too. I think you have to leave the school because maybe I'm going to lose my job and your daddy too. But he said, Mom, I don't want to leave my school. And I said, maybe you have to.
And I apologize,
but I thank you for working hard. I don't want to leave O'Connor.
Thank you very much. I do want to ask everybody to please limit your remarks to 1 minute. When that beep goes off, it really is time. Thanks. That being said, if we could ask the clerk to limit the beeps to 2, just so it's a little less in your face, I believe is the parliamentary term I was looking for, okay? A little less of that. By the same token, want to ask people to please stop when you get to a minute. And come on up. I have cards from Eva Renteria and Frank Vieira and Josiah Arellano. How about Edelmira Arellano or Deborah Bastol? Is Deborah here? Deborah? Come on up and help me pronounce your name properly, please. And we won't count that against your 1 minute, I promise.
It's Bastholm.
Thank you. I want to welcome Deborah Baston.
Thank you.
Thank you.
And thank you, Dr. Smith. On May the 25th, I had surgery for, May 14th, I had surgery for cancer. And in that, I had to be over there at the county. That was on July the 25th. I had to take the test. At the time, I had a drainage tube, and I was NPO, could not eat anything. I had to be over to Clara Hospital for another surgery at the day of the testing. I didn't pass. So a lot of mental and physical duress. I've been at O'Connor for 30 years. I worked med-surg oncology, I worked ortho, I worked PCU, and now I'm in subacute. Very dedicated nurse. I love my job. But under the circumstances, I didn't pass the test. So in retrospect with that, I want to stay at O'Connor Hospital. It's been my home. My husband also works there. He is a CT, 30 years. We both do, so.
Thank you very much.
Okay, thank you.
All right, how about, we have cards from, could be Elvia or Elvira Castaneda, and then Irma Morales, and Adelaide Reese, and then Carl Beck, and then Edelmira Arellano, and Maria Berry? Okay, come on up. Just tell us your name if you would, please.
I'm Elvia Castañeda. I work in San Luis Hospital for 21 years. As soon as I receive the letter, I don't pass the test. After the day, I feel very stressed because I work here for 20 years and I think I doing my job really good. That's what I working longer. And I have my son, and he dependent about my insurance. I have a disabled son. He's in the wheelchair. So I really love my job. I really want to keep it my work over there. I love my job because we're working with all these good workers, and now some people pass, some people don't pass, so we feel like something's broken. Nothing is the same. So we want to feel the same to keep it all together, like a community working really good for the patient and for the community. So I asking for help to keeping us working like a family in there. This is my second house because I working for 21 years. So I not imagine out of my work in the hospital.
Thank you very
Thank
much.
you.
Could our next speaker come on up, please?
Hi, my name is Irma Morales. I work in San Luis for 16 years. I am a hard worker, always I there when they need me. I was in my day off when the Garlic Festival, the tragedy. As soon as I get the call, I will run away. 5 minutes there, I was there helping people. Not only clean blood from the floor and walls, we pushing beds, giving support to the people, get a shoulder to cry, give blankets and a cup of water. And a couple of days later, I get an email that I don't pass my test. We want the job. It's only we want the job because if we don't have the job, we don't go have the kids in the streets. I had my son in college, and I supporting all my money to him.
Thank you very much. Who's our next speaker, please? Come on up.
Sorry, my name is Adelaide Reis. I work in the hospital in San Luis for 20 years. I'm the one I work there for my family, but I wasn't gonna work anymore. My son is very sick in the house, and I work for support my family. So thank you so much for you talking today, and Mrs. Smith, and thank you, my heart, who you do for us. Please, listen to us. Our work is my second house. I work there for a long time. I do my job. I'm employer the month for 3 times, employer the year for 1 time, because I work. I know too much in English. I can read it because my language is a Portuguese. And I'm proud, and I I thank you so much for what you do to us, and that help us stay all the job. I appreciate that. Thank you so much.
Thank you for being here. And next speaker, please.
Hi, my name is Carl Beck. I also work at St. Louis RN. I just want to thank you for extending, and I'd like to thank the county for the resources that you've put into our hospital. But the way they're treating the housekeepers I thought was unjust, and that's why I'm here. It didn't make sense in the justice part of it, which you guys make us learn about. It doesn't meet your own standards. It doesn't even make economic sense in that you're going to have to bring in new people, train them for people who are already doing a job, and nor do I even think the test reflects the job they're doing. I don't know what the test was. I didn't take it, but it's unjust, and you've addressed it. Thank you. Proposals that I have is, why don't you guys have like a blue ribbon panel from people not just tied up in the county, but people who are also outsiders that come in, take a quick look. That way you can develop plans, policies, see if these guys are doing the job, and I think that would help. Thank you.
Thank you very much. Could I ask our next speaker to come forward, please?
Good afternoon. My name is Eva Renteria, and I have worked for O'Connor in the EVS department for the last 28 years. I've been offered extra help, but I cannot lose my health insurance. I take medication that out of pocket would cost me $350 a month. It is unacceptable, wrong, me and my coworkers to be offered less than what we have now. Please accept Mr. Smith's proposal. Thank you for listening.
Thank you. Who's our next speaker? Come on up, please. And forgive the interruption, is there a translator, or is it just the two of you who wish to come together?
I'm going to translate her part, but then I also have a part for myself.
Okay, so let's start with her part if we could. What I want to do is ask the clerk to double your time so that the translation time doesn't count against the time for you to
Okay.
speak, okay? So
Thank
let's
you.
start with her part.
Okay.
And forgive me for calling you her, but I don't know your name yet, so there you
It's
go.
okay. So her name is Eldemir Ariano. She has worked at O'Connor Hospital for 21 years, and she's been a janitor since she came to the U.S. She came to the U.S. at the age of 16, so as you could have assumed, this is all she knows how to do. She was one of many workers who were told that she has 90 days because she did not pass the test. The reason she did not pass the test is because she cannot read or write in English. But she's a good worker. I've seen it with my own eyes. I've been going to work with her when I was younger because there was no daycare, no nothing. And she's eager to work, and she's eager to learn, and she would like to train and work for the county. The test does not define her intelligence. What does define her intelligence is her actions. So I please urge all the supervisors to please accept the proposal that Dr. Jeff Smith came so that O'Connor can keep their employees and they can stay as a family. Thank you.
Thank you.
Okay, so my name is Josiah Ariano. My mother is Eldemir Ariano. She is an O'Connor janitor who is going to lose her job. I am 20 years old and a full-time student. I am going to school to be a social worker because I want to work with and help children. If my mom loses this job, I will have to drop out of school to help keep our house. I feel like this test is taking my dreams away. I know I have potential, but it will be squandered if this issue is not fixed. Since I was a child, I have been coming to work with my mother. I have seen with my own eyes she can do her job well. I urge you all to come and see for yourself. This test is no indication of my mother's intelligence. The past few months, I've tried to assure my mom everything would be okay. I feel like I've been made out to be a liar. As a diabetic, I take medication that regulates my blood pressure. I also take medication for anxiety and depression, as well as testosterone shots weekly. Being transgender, if I lose this will send me back a year of my transition. All of this can be avoided by giving my mother the job she deserves with her health insurance benefits. I urge the supervisor to please approve Dr. Smith's plan so my mother can keep her job and become a full-time employee. Thank you. Sincerely, a proud son of a single mother and janitor.
Thank you. And that was Josiah Ariano, yes?
Yes.
Thank you so much. Okay. And we have a few more cards. Folks, we're starting to get sort of more cards and more cards. Let me just ask, if you want to speak on item number 2, public comment, we need to get your card in the next 60 seconds so we know how many folks we have and how much time we can allocate. I understand sometimes people want to talk at a particular time, but we kind of need to make our way expeditiously through this process while still making sure we hear from everybody fully. So, Frank Vieira, are you here? please come forward. And I believe it's Maria Kingsbury or Kingsburg. Are you here? Apparently not. One moment, please, Mr. Vieira. Dolores Alvarado or Alvaran? Yes, please. And then Sarita Coley. Come on up, please. Thank you. And as I say, unless we get another card in the next 30 to 60 seconds here, that will be it. Mr. Vieira, welcome.
Yeah, Frank Vieira. I'm 11 years working in St. Louis Hospital. I'm a lead housekeeper. And Mrs. Smith, thank you what you did today. It took a big relief from us, our department. We can, relax a little bit more. Nothing's done. I think everybody should go behind Mrs. Smith and back his back. He did a beautiful thing today. Mr. Paul, thank you for doing everything you can for us. And Mr. John from the St. Louis Hospital. We are, yes, great coworkers. We do our job professional. When we have a Joint Commission inspection there, we can look at the floor when they come in. We got great scores. That is what we do. We're not good in doing tests. Yes, we don't do that very good. But in job 100%, we are there for our community. We are there for our patients, families. And I think that's what the best we can do. And thank you again for everybody, Mr. Smith and everything. Thank you.
Thank you very much. Dolores Alvarado to be followed by Sarita Coley.
Good afternoon, President Simidian, Supervisor Ellenberg, Dr. Smith, Renee Santiago, et cetera. I'm here for two reasons. My name is Dolores Alvarado. I represent the community health clinics. Number one is to thank Ms. Ellenberg, Supervisor Simidian, Dr. Smith, and Renee Santiago for the excellent conversations we've had regarding the FY19 subsidy item that came to the board last week. So thank you for that. I think the contracts are moving forward very nicely, very realistic, good outcome metrics, et cetera. What's still pending is the issue of the unilateral indemnification clause in the contracts. We've been working with this with staff, county council, et cetera, since January of this year. The current language as written places undue financial burden and liability on our health centers for anything that could happen to the patients. Unilateral indemnification, darn it, we're asking for mutual indemnification, but here's the information.
Thank you very much.
Thank you.
Ms. Cole.
Thank you. Good afternoon. My name is Sarita Kohli, and I'm Vice Chair for the Community Health Partnership Board. And I'm here speaking on behalf of all of the community health clinics. And I just want to thank everyone here, and especially your leadership, President Simidian and Supervisor Ellenberg, and thank you, Dr. Smith, for all the support. I'm echoing what Dolores had said, and continuing what she started on the universal indemnification. We're really requesting for FY20. I think we're ready to sign the contracts other than for this one piece. Failure to change the language from unilateral indemnification to mutual indemnification will place the clinics at risk of losing the liability coverage under the Federal Tort Claims Act that all of us have, and which protects us in case of lawsuits from patients. Without this protection provided via the mutual indemnification agreement, the clinics may not be able to continue operating because none of us have that kind of deep pocket to be able to financially support a major lawsuit alone. So please take a look at that, and thank you again for your support. We're part of your system of care. Thank you.
Thank you very much. Let me just confirm with the clerk, I don't believe we have any other cards for item 2, public comment. The card I just got is for item 5. Okay? No other cards? Then we will say thank you to all of the speakers and all the folks who took time to be here. For those of you who are not regular participants in these meetings, I perhaps should mention that we are precluded by law. We're not allowed to weigh in on non-agendized items, let alone take any action. So since the items that you're speaking to are not on our agenda, we cannot take any action on them. However, Dr. Smith, if you'd like to speak briefly, just to sort of give us an update and or share with folks who came the status of some of the topics, please feel free to do so within the limitations of the Brown Act, which I know our attorney will remind us of if we stray too far.
Yes, thank you, Mr. President. The first issue is that I had a very positive meeting this morning with SEIU. There were probably about 30 people there. Most of them were janitors. There were others from other classifications. And the meeting was at O'Connor to discuss, among other things, the number of individuals who did not pass the ranking test as part of our merit system dictates. I tried and I think successfully explained that the merit system really isn't designed very well to hire a large number of people all at one time. But the bottom line is that we're going to come back to the full board in the next 2 weeks and ask the board to create sufficient new unclassified positions so that all of the employees of the previous Verity hospitals, O'Connor and St. Louis, who didn't pass the test will be able to be placed into one of those unclassified positions as we end the current recruitment, which will close out by the end of the year, and then we'll start a new recruitment to get those individuals into permanent classified positions. So the unclassified positions will not lose any retirement, health benefits, or salary, and we will be discussing with the union and labor relations how we can change around the testing process and the ranking process. As the board knows, the merit system envisions 3 levels of tests anytime we're doing hiring. One is to test whether people meet the minimum qualifications. One is to rank them in some testing manner. Each classification has its own way of doing that, and the other is interviews with the hiring authority. So for those individuals who didn't make it through the ranking test, we know there are many reasons, and some of them received 90-day notices. I made the commitment that they should ignore those 90-day notices because we'll get through the unclassified process before that's done.
Thank you very much. And I do see that the light is on from our county council.
Just at the ready.
At the ready. All right, good.
He can give you an update about the indemnity issue.
No, I want to make sure he's not charging us by the hour while his mic is on down at that end of the podium. Thank you very much. All right, Supervisor Ellenberg, that concludes item number 2, public comment. That takes us to item number 3, which is to approve the consent calendar.
Supervisor,
Yes.
did you specifically not want our attorney to give an update on the indemnification piece?
I don't think he was
But he was ready
offering,
to.
and I am not asking, and I think having a conversation about a legal matter in an open and public meeting is probably something he's going to advise us against anyway, but maybe I shouldn't be a mind reader.
It sounds like you're a mind reader. I was going to advise you that we can prepare a confidential memo for your consideration on this very topic.
Good. Well, thank you. I'm glad we got you to lean in and say that. Thank you, Supervisor Ellenberg. That takes us to item number 3, which is to approve the consent calendar and changes to the committee agenda. We have a number of items on the consent calendar here today, but before I turn to Supervisor Ellenberg and ask for a motion to approve the consent calendar, I'm going to turn to the clerk of the board, who I think has an announcement that she wants to share, and then I have one brief item on the consent calendar as well. Madam Clerk?
Thank you. Due to a clerical error, item numbers 12 and 17 are duplicates. I'd like to request that item 17 be deleted from the consent calendar.
Okay. And Supervisor Ellenberg, I would gratefully entertain a motion to approve the consent calendar as published, with the exception of the deletion of item 17, but also the continuation of item number 11 regarding our emergency medical service and the status of our EMS agency and calendar, continuing that to our next meeting. So moving approval, if that's agreeable to you.
So moved.
All right, so we have a motion from Supervisor Ellenberg, and again, bear with me, folks, because of our overhead, I'm going to be a little bit more precise on some of this. Motion from Supervisor Ellenberg, seconded by Samiti, and there are no comment cards, or I would have taken comments, to approve the consent calendar with the exception of item 17, which is deleted as a duplicate, and item 11, which is continued to our next meeting. In the absence of any objection and hearing none, the consent calendar as amended is approved. Thank you, Madam Clerk. Okay, that was pretty bureaucratic. Let's go to item number 4. Item number 4 is to consider recommendations relating to medical staff and allied health professionals at Santa Clara Valley Medical Center, O'Connor Hospital, and St. Louis Regional Hospital. And we have with us to present on that.
Good afternoon, Board of Supervisors. My name is Yvonne Karanis, and I am the president of the Enterprise Medical Staff, and I'm here to present the credentials report and answer any questions if you have them.
Thank you, Madam President.
Thank you.
And Supervisor Ellenberg, this all looks in order. Any comments or questions?
None.
Then a motion to approve
So moved.
and ratify. And that motion is made by Supervisor Ellenberg. I am prepared to second. I will confirm with the clerk we have no cards on this item. We do not. And then without objection, hearing none, unanimously approved. Thank you very much. Appreciate your being with us as always. That then takes us to item number 5, which is to receive a report from the Behavioral Health Services Department relating to work plan and accomplishments from the prior fiscal year. And before we go, I gather, Ms. Tully's to you for the presentation on this. We have about 9 or 10 cards on this from folks who would like to speak. I want to make sure we hear from everybody. On the other hand, I want to make sure we have time to actually talk about the subject in our meeting today. So how about we see if we can adjust it to 90 seconds, give people a minute and a half, and ask people to adjust accordingly. And also, if you are a me too or I share the same concerns, rather than repeating what's already been said, that would help us make sure that you get a chance to register your point of view, but also that we have time to make our way through the topic. And I'm thinking, Ms. Tully's, if it works for you and for Supervisor Ellenberg, maybe we can hear from folks what's on their mind first, and then you might be able to address some of the issues during your comments. Yes? Okay, all good. In that case, I will indicate that we have cards from Megan Willehan at the Law Foundation, and I believe it's John Solomon Martinez and Jennifer Jones and Nava Statman and Elisikoff Ginsborg, and then we'll go to another 4 or 5. Come on up in that order, please, if you can. But just don't worry too much about the order. Just come ahead and tell me who you are, and I'll keep track. Welcome.
Hello, dear brains. My name is John Solomon Martinez, and I would like to start off. My infant brain days, I speak.
I'm sorry, Ms. Shaw, I apologize for interrupting, but if we could ask the clerk to raise the volume to be sure that we can hear you, and I'm going to ask the clerk as well to reset your time so that you have the full minute and 30 seconds.
Okay.
Thank you again.
Hello, dear brains. Thank you for noticing and for being intelligent to rise the situation to our hands here in our brains. As I said before, my infant brain days, in my infant brain, I speak English and Spanish, and I'm 34 years old, and I'm still a V, and I'll let you, add those other alphabetical letters to have you decide whether it's a healthy thing or an illness thing. So my case here is, as you know me very well, I've put in complaints about, why people are medicating me. And the thing is, you guys don't know that I was intoxicated when I was 13 years old. And the police officers, did not, do a very good job, but we all have a hard time, right? And we all get, hit and attacked, but I know that we all maintain firm. So when I was 13 all the way to 19, they drugged me up street drugs. And then for the miscomprehension and incapable of people understanding me, I was medicated from 19 all the way to 25. And the thing is, not everybody is mentally ill. Some people, are born with, the blessing besides the mother and father. And I'm just saying that I need recovery. I'm not a criminal mind, and that's why I speak here, that, don't catch all because not all are criminals. Thank you.
Thank you. And we'll follow up with our staff. Thank you.
I got this right here.
I'm going to ask the clerk to take that from you, and she's going to copy it and make sure that we all get copies of your statement. Thank you. Madam Clerk, thank you for that. Good morning and welcome. Good afternoon and welcome. Forgive me.
Good afternoon. My name is Megan Wheelahan. I'm speaking on behalf of the Law Foundation of Silicon Valley. In my work, I represent many of the vulnerable community members for which AOT purports to be the right tool. I meet people at the point that the tool of forced treatment has already been used. They are in a hospital against their will, maybe taking medications against their will. Yes, that tool got them to the hospital, and yes, that tool got them taking medications. But what I hear so often is, I'm just doing whatever I can to get out of here. That is not true engagement, and that is not ownership of recovery. We already have the tool of forced treatment, and it is not what makes the difference for the distressed person that you see on the street and for the young man whose family is struggling to find him help. What all the research shows is that intensive, whatever it takes, meet them where they're at, culturally competent services is what can engage people and show them that there is help available that can actually get them to where they want to go and which can prevent reoccurring crises. That is the tool that works. Adding an enforceable component to that kind of approach actually weakens the tool. If the provider knows and the client knows that a threat of a court order looms in the background, then the engagement is not entirely involuntary. There is that much less of a reason to meet the person where they're at. I applaud the Behavioral Health Services Department for these extraordinary efforts to bring more than 1,000 additional intensive treatment slots to our county and for increasing options to family members. Thank you. I encourage the board to emphasize voluntary tools.
Thank you very much. Come on up. Who's our next speaker, please?
My name is Jennifer Jones. I'm a consumer with over 22 years of psychiatric treatment and therapy. I am an LCSW and have been a manager of county's consumer affairs program for over 12 years, and I'm a survivor of forced treatment. Forced outpatient treatment strikes fear in my heart as a consumer about my human rights being taken away if someone feels I need to be forced into outpatient treatment. I'm in complete agreement that there's a need for client engagement and services. Studies show that it isn't a matter of whether or not a person was forced into treatment, but whether or not services were available in the community. Santa Clara County has made a great deal of progress in offering more relevant and effective services such as crisis stabilization unit, peer respite, and mobile crisis team, to name a few. So I believe client engagement is important, but it needn't be forced. These services increase client engagement, which is what really promotes recovery. Many years ago, I was prescribed Depakote, which I took for 10 months. During the whole time, I was suicidal day and night. I decided to go off that medication. I was non-compliant. Thankfully, for the first time, I was freed from suicidal thoughts. Later, I went back to treatment voluntarily, but this time I took control of my treatment. When I was forced into treatment, it held my recovery back. I remember being hospitalized years back. I went involuntarily, but then it became forced, and I felt worse. There's a big difference in your overall recovery if it's voluntary versus forced. If you have never experienced that, how would you know the oppression that is felt from being forced to do anything?
Thank you very much. Nava Statman, and then Alyssa Koff-Ginsborg. And as they're making their way down, I'll say David Mineta is also on the list, as is Aaron O'Brien, Kathy Forward, and Mark Cloutier. Welcome.
So my name is Nava Statman. I've served for many years on the mental health board for this county, also served as a president of NAMI, but I'm here as a parent. I have a daughter. She's 47 years old, and she suffers from severe and persistent mental illness. Every 18 months or so, she goes through a severe episode, but it takes her 9 months to recover. She's one of those consumers that the case manager closes the case on and says, never been seen in 90 days. So I urge you to really look at the report about AOT that the mental health department, behavioral health department had attached to this report. I have not been advocating for it for the past 20 years because every time there's discussion about it, people talk beliefs. They don't talk facts, they don't talk figures, and they don't talk results. And in this case, you have a report that shows a positive trend, and this is a report from the state that covers several counties. Not only does it show positive results, but it also shows the potential for the other consumers in the systems to benefit because it does free funds. I do not know what the right answer is, and I do not want to argue personal liberties, but I do not know how much liberty there is in being homeless and being out of it, not able to procure your food, and so on and so forth. But thank you.
Thank you. Next speaker, please come forward.
Good afternoon. I'm Elisa Koff-Ginsburg with the Behavioral Health Contractors Association. I'm here today with leaders from several agencies that provide services in our county. I'd like to highlight a few things from the letter that I sent you and to the clerk of the board. As you discuss what services are launching or could be added, we urge you to also focus on some things the county can do to make the system more effective for clients. These include instituting immediate communication with a person's existing provider if they come to EPS. Providers can't follow up because the client may not come and tell them they've been to EPS. We recommend training across the system and use more extensive use of AB 1424 form so a family member can provide information to better inform client care. Finally, outreach and engagement needs to be bolstered and target both identified and non-identified clients. Current behavioral health outreach targets clients who are falling through the cracks in the system. An important additional effort is to target those who are entirely disconnected. The homeless mentally ill outreach team sends clinical providers to the client wherever they are in real time. This group of clients can't use traditional methods like the call center.
Thank you very much. Next speaker, come on up.
Good afternoon, Chairman Smitty, Supervisor Ellenberg, County Administration. And I'm here to finish off Elisa's statement. So, again, I'm David Mineta from Momentum for Mental Health and also a member of BHCA. So to continue, this approach needs to be made available to all outreach teams in our county, including the CBO teams. Another group that needs more outreach and engagement are people who have been but are no longer under conservatorship. Every person in the situation should routinely be connected with a case manager outreach worker whose responsibility it is to provide ongoing check-in and initiate re-engagement immediately if needed. The timeliness of that is so key. So BHCA urges you to direct staff to explore these recommendations for better engaging those most vulnerable and hardest to serve. We look forward to working with Director Tully's on all these recommendations, and we appreciate having discussions in the community with Supervisor Ellenberg on this and your efforts to really get into this very difficult issue.
Thank you very much. Next speaker, please.
Good afternoon, Erin O'Brien. Thanks for the opportunity to talk to you today. I'm going to be echoing some of what you've heard before. I think that the importance of outreach and engagement in these services cannot be overstated. And I think it is important that we have the outreach teams, but I think it is equally important in these new programs that are deep level intensive that you have sufficient engagement within them. Because some of these folks are extremely resistant to treatment, and when they come in is when they have the relationship, that they build that relationship with the person that they're going to be seeing on an ongoing basis. And I will say, when we first had the full service partnerships, I think of one client that we had who was living in what was called the villages out along the creek in Gilroy. And at first she wouldn't meet with our staff, and our staff would go back every day. And then eventually she accepted a phone from them. And then eventually she would call them, and then she would meet them for coffee. And it took a while, and she came into services. She got clean and sober. She is living independent. She is the epitome of the success story of what can happen when we're able to do engagement effectively. So I would really encourage, as we look at these new programs, to focus on that and on these populations that we are frankly serving insufficiently at this point. And I also want to call out kind of an acknowledgement to the department. I think that we have to work with the state, because as the state is coming down on us on timeliness, the clock starts ticking on how we're engaging these folks, and we're supposed to get them open within 10 days. And these are hard to serve people, and we need to be able to have the time to engage them successfully so they come into services voluntarily. Thank you.
Thank you.
Hi, Kathy Forward from NAMI, Santa Clara County. I'm happy to be here this afternoon, and I just want to add on to what you're hearing, because engagement, prevention, early intervention is what we all should be looking at. So much of our services are in silos, and we need to have a bigger picture We shouldn't be waiting until people get arrested to go into the mental health court where the equivalent of AOT is happening. You know, Judge Manley does understand the principles of it, but it's a shame that we are waiting till that point. I'm not necessarily advocating for AOT. I think it's necessary that we have more, engagement, and we should be not waiting until people go to the hospital, and meet the criteria. We should be engaging people at every level that they are and trying to keep them out of the hospitals and keep them from becoming homeless and keep them from getting arrested. And I think if we can focus in a bigger picture and bring these services together, that we can have some success. And it would be great to see some of the statistics on how these services are working, the Pay for Success project, the FSP, because we do hear the stories from the families and from people calling our office. And quite often, there is someone saying that they were on an FSP team, but they were so hard they got dropped or whatever. But I think we really need to find out what is happening and to make sure that people are not dropped and that there is continual engagement on lots of levels. Thank you.
Thank you. And I think that brings us to our last speaker on this item, Madam Clerk. Welcome. Come forward.
Good afternoon. My name is Mark Luthier. I'm the CEO of Kaminar, which is a behavioral health provider in 3 counties in the Bay Area. We provide FSP and assertive community therapy that's been a part of implementation of AOT in San Mateo counties and Solano counties. And I'm here today to urge you to consider implementing AOT. And I obviously have a bit of a conflict of interest since I operate services that are part of the response, but I'm here actually to talk to you as a former bioethicist and to suggest that what we need to have is a Board of Supervisors hearing on this issue, because as we've heard from previous comments, this is a very cherished set of issues or values that are in conflict with each other about taking autonomy away from people who, for a variety of reasons, have not been able to exercise their autonomy in their own good and may be a threat to each other, and that we're considering using coercive or state power to require them to do something that we know as professionals, when you require people to engage in behavioral health, you don't necessarily get good compliance. So I urge the board to reconsider this issue, to have public hearings, and have a vigorous public conversation about this issue. Thank you.
Thank you very much. Let me just confirm with the clerk, that's the last of our speakers on this item. Ms. Tullies, before I go to you, let me just thank everybody, and I should have said this earlier, in both groups of speakers for working with us in terms of the time limits. Sometimes we have 2 minutes, 3 minutes, but it's the chair's prerogative when there are lots of speakers to limit the time somewhat differently. It's always a hard call, frankly, because we want to hear from people. Just so you know, one of the things we've done is added a half hour to the length of our meetings so that we can accommodate public comment when folks have things to share with us and still make our way through the agenda. So I just wanted to say thank you for that, and also make sure that people understood that that's why there was a little bit of a difference between one time limit and the other. All right, Ms. Tullies, I believe we turn to you now for the opening comments before the committee members here engage.
Okay, so I want to provide a few remarks, and then we do have a PowerPoint. We're not going to go through every single piece of it, but we can talk about it. I want to begin by thanking the board members and the administration for being so supportive of behavioral health. Over the last 4 years, our budget has been increased by about $50 million, and we've almost doubled our staff. We've expanded all of the services with the contract providers, and that's because you support us. I also want to just do a shout out. There are a number of our staff here today and many of our contract providers, and I think that this work that we've been doing, especially in the last year, is really a result of everybody focusing on what are we doing to serve the clients, how are we doing it differently and better. I think it's been an authentic collaboration with all of the providers, and I'm very, very proud of the work we've done in 2019 with all the people who've been involved. I wanted to do a little bit of a highlight on this work because I think it's really important, and I've raised this before, to share with the board members what is going on in our field here in California. I want to give you just some local information in the last 24 hours. We've been following at the state level 72 pieces of legislation that are directly focused on mental health and substance use, 72 pieces of legislation. There are many types of legislation that are out there. There's a big focus on the Mental Health Services Act funding and what might happen there. Quite a bit on the regulations related to the managed care final rule, and a variety of programs that have put on suspense, but will have the opportunity to come back in January of 2020. The other thing that I wanted to bring up is our future state. There are multiple conversations. You're going to hear this from Renee Santiago, but the Department of Healthcare Services has been very clear that between 2020 and 2025, the intent is that our county mental health plans and our substance use plans will be somehow or rather integrated into the medical managed care plans, and there'll be a lot of work. It's going to be a very busy time for people in our field. But most importantly, what I want to discuss is the great success that we've had in the last year, and I want to highlight a couple of things. This report talks a lot about all of the new services, all of the things that we've been able to accomplish, but I want to lead with the most important thing that happens, and that is our consumer and family relations within the department. And in fiscal year 19, the Office of Consumer Affairs and the Self-Help Centers served almost 1,300 individual clients. So while we're doing big picture things, what we're primarily doing within our system, and this is within the county operated, and we know that there are more in the contract agencies, that we have not at all taken our eyes from what matters most, and that is helping our clients and consumers towards wellness. And I support all the comments that you've made about enhancing engagement, and I think that's the goal of the new programs that we're putting in place. So we can look at the work plan and accomplishments. I know you have many questions, so I thought I'd go through this really quickly, answer your questions, and then move into the assisted outpatient treatment, if that works for both of you. So this will be brief. We have in our work plan 4 different areas. So we look at administration and organizational integration, our service delivery. We'll look at those quickly. I think you'll see the organizational chart and all the great work we've done with procurement processes and all the contracting work under our organizational piece. But I think the biggest focus for us this past year has been the service delivery. And I think the most important accomplishment this year for us has been a 12 to 18-month process, working with the contract providers, finance, program, and contract, the three pieces of the organization, to really look at those contracts to provide the increase for clinicians and for quality improvement staff, and to tighten up the language so it's clear what we're expecting of people within each of those contracts. It's been a long process, but I think it's been very effective. It will be sustainable, and we're still learning from the providers, but many of the things we put in place will be able to go on year after year after year with little tweaks, and I'm very proud of that. I know that you are as well, and I know that the contractors are as well. Our mobile crisis team, we've increased the staffing. We're now working with recruiting voluntary on-call staff. We've seen hundreds of people in the course of the last less than a year now. And I want to highlight a couple of things. One is that we have a couple of staff, we're training 3 more who are taking courses on working with law enforcement in crisis situations. In the last 2 weeks, there have been 3 or 4 situations where people have been inside their houses with weapons, and our team has been back behind the ropes, providing behavioral health counseling to law enforcement. And 3 of those 4 were put right into services, and 1 was put into custody. But that kind of work didn't exist in this county before, and it's pretty extraordinary that the majority of people that we've seen in mobile crisis have wound up in services with a very small number on 5150s. So that's changing the landscape here. We are standing up these new programs. I know there are a lot of questions about those, and it does tie into the assisted outpatient treatment. We'll be standing up what we're calling intensive full-service partnerships and assertive community treatment teams, and also a forensic assertive community treatment teams, highest level of outpatient services in our field. They've been in play for many, many years. The outcomes are consistent and very positive. They are totally focused on 24/7 support, and we anticipate that it will take some time to engage this client population. Both of these programs are very well funded based on common practice in California and across the country, and they're all contracted out. So we're very, very excited about this. There were questions about the timeline. We're moving this until October because these are brand new services, and the contractors want to be able to hire the staff. They've had lots of training on this area, and we'll continue to keep you informed of how this works. But these were big gaps in Santa Clara, and they're the same programs that we've heard in other counties. It's the exact same programs that they're using for the AOT programs, all voluntary. So can we just switch? Is it you? Okay, I'm just hitting a few on these. I think the other biggest thing for us, and absolutely at the top of our list for 2020, we have not had a functional EHR, electronic health record, to manage a system of going on 40,000 clients. And so we've been able, you've signed the contract, we've got NetSmart on board. On my avatar, we're moving very aggressively. The intent is that the EHR will be operational just around the beginning of the fiscal year. And we do plan to create an interface with HealthLink so that information is available to our staff across the health system. But the implementation of NetSmart will allow us to really manage a managed care system. So that's big, big, big. And I think you can see the list of all the accomplishments, the emerging issues and opportunities. I'm very proud of I think the county is as well. We have the lowest suicide rate in California. That is a big effort by tremendous staff and community partners. We're launching Alcove. We're in the preparation for that on implementation. That will be the first in the United States. We have the first in the United States on our Pay for Success program. And while that is a more complicated report out, I do want to say we just received the first big evaluation from Stanford, and we've seen reductions in emergency psych. We've seen reductions in hospital stays. So while we still have some people that are winding up in EPS, those numbers have dropped tremendously. I think I'm going to stop there because I know you and your staff have looked at all of this, and I want the public to be able to see all of the accomplishments, and then open it up to questions for the supervisors.
Thank you very much. Ms. Ellenberg, questions, comments?
Yes, some of both. Thank you, first of all, Tony, to you and your entire staff. I really appreciate the great work that's reflected in this report across the Behavioral Health Services Department. I thank you also for your patience with me. I know I have pushed persistently on questions, and that's going to be my MO. And until I deeply understand, I will keep asking. This report really demonstrates the important work that's underway to both improve department operations, as you mentioned, in infrastructure, as well as to add new services to address gaps in the continuum of care. I found the reports from BHSD, the DHCS evaluation of AOT programs, and the memo provided by BHCA as really helpful resources in clarifying the core issues in meeting the needs, particularly of difficult-to-reach individuals with severe mental illness. I believe that our core responsibilities as a county are to assure evidence-based intensive services like ACT are available and implemented effectively, to assure that our outreach efforts are exhaustive to reach individuals and their families who need our support, and to evaluate the outcomes for these services, including justice system involvement, housing instability, and hospitalization. Hearing all of the comments today was helpful. I support the use of a voluntary service model to achieve our goals and provide care to consumers, even those that have been challenging to bring into care. So to that end, I would like to ask that your department review and report back to HHC on the feasibility of the recommendations in the BHCA memo, in particular with regard to mechanisms for outreach and linkage to services, and any additional information on current and proposed approaches in behavioral health, OSH, or other county departments. Also, in terms of evaluating the outcomes of ACT and FACT, what would you recommend as a reasonable schedule of outcome reporting?
I think it will depend upon how quickly people are engaged, and that's what the providers are talking about with ACT. It really will take, it could take some length of time to get people who've not been involved in services to get connected to services. And in talking to other counties who do ACT and FACT, sometimes you can get somebody engaged quickly. Most of the time it takes a little bit of time, some months. It could take some months. What we could do is report back to you at HHC on a quarterly basis in my report about where things stand, how many clients have been enrolled, and I think that would give you a lot of information about the process and the implementation. And then as we move forward with more and more clients, we'll be able to come back
To
with
build data.
I would like to do that.
That would work. Does that work for you as well?
It's fine, thank you.
I'd also like to get an off-agenda report on the evaluation of pay for success. And lastly, I want to commend the department for achieving the lowest suicide rate of any county in California. I know that there is still so much work to be done here, and I look forward to continuing to support your work, including continuing the annual Suicide Prevention Conference and looking for additional opportunities to partner with school districts and other education partners in this work. Thank you again.
Supervisor.
And, one final comment,
Please.
which I've made to you privately, but I'll do it on the record. We are doing so much good work, and the people in here know about it, and the people watching this do, but far too many people in the general community have no idea how much work is being done here. And I would love for you to find a way to really push this out to the public at large, to let people know that Santa Clara County really is on the cutting edge, that we do care about these issues, that we are working hard, and we are being effective.
Thank you, Supervisor. That's our wish as well.
Great, thank you.
Thank you very much. Ms. Tully's, one of the challenges here, and we have the same challenge, in my view, in some of the reports that are coming on other agenda items, is there's so much information, it's a little hard in some ways to sift through and find the sort of key points or the nuggets. So if we asked you to take all of this very complicated work, which represents thousands of folks and years of work, and say, what are the 3 things you want us to take away from all this, so that when we walk out the door, we remember 3 things? What are the 3 things? And I pick 4 because 3 rather than 4, because 4 is too many to remember, and I pick 3 because 2 is not enough to be impressive. So I'm looking for 3 that I can remember as I walk out the door. I know what I think, but I'm curious to know, as the leader of the organization, what you think.
I have to say, I think it's about really looking at all of the needs, all the gaps, and the expansion of services. I think we have expanded we are implementing the services that were needed in the county. I think that we're using a lot of evidence-based practices and evidence-based standardized tools. And while we talk about what's going on with the adult system, when we look at the children's system, we're also using a lot of evidence-based practices, and we know if we can get that right, we can decrease the number of adults with serious mental illness. So number 1 to me, it's always about the people we serve and having the right array of services, the right continuum that's culturally responsive, that understands wellness and recovery and trauma. I think that's what we're doing.
Okay.
I'm very enthusiastic,
But bullet
Supervisor.
points, I'm looking for bullet points here.
point.
I'm looking for the
Continuum of care, a complete state-of-the-art, evidence-based continuum of care.
Okay.
Number 1.
And her second point is?
My second point would be, I think that we are doing, both in substance use and mental health, I think we're doing a lot of very effective prevention and early intervention. You're seeing that in suicide prevention. You're seeing that in the work that we're doing with substance use. And I cannot emphasize enough that if we don't focus on the prevention, we'll just continue to have more and more adults go into our mental health system. And using these tools and doing this prevention will save lives and help people have healthy and happy lives. That's number 2. And number 3 is really working with the providers and looking at the contracts. We're going to continue to try to improve those contracts and working together in a time of great change with managed care. I think there's a very strong partnership here, and I think that that is the best thing for the county and for the beneficiaries we serve. Those are my 3.
Got it. Thank you. Looking at the materials, there are, I think, 3 important efforts that have October 2019 dates attached to them. One is the FACT, everything's got an acronym, so the Forensic Assertive Community Treatment, which comes with ACT, the Assertive Community Treatment, October 2019. In-home outreach team, October 2019. Intensive full service partnership, October 2019. We're in August, so October's not far away. Are we really going to be doing these 3 things in October?
My understanding from the staff is absolutely we will be.
We are perennially challenged in terms of hiring. So does that mean that either we or our contractors have hired or
Some have hired, some are hiring, and the only thing I think that would cause a delay is if there's a challenge recruiting the staff that are needed for these programs.
Well, every time we talk about hiring, there's the word challenge is in the conversation, as you know. So I guess I'm turning to Dr. Smith and to you to say, a lot of work's gone into it. I don't want to discount this, but we've been having these conversations for a very long period of time. So to underscore the sense of urgency that Supervisor Ellenberg hinted at earlier, I just want to know, what's it going to take to make sure that we don't have a meeting where we say we thought we were going in October and it turns out there's been a 3-month, 6-month, or year-long delay? Because I want to do that now rather than have an oh my God moment. And if it sounds like I'm anxious about it, it's because I am. So I'm just asking.
Well, I think we're giving you our best estimate, and I don't think we can give a guarantee because lots of the factors are not within our control. So trying not to be flippant, I think if we want a guarantee, we should push out the date beyond October. I mean, there are only so many providers out there in the market, and lots of people in need of them. So I don't think we can guarantee that we'll have everybody hired by X time.
You know, in the 6.5 years that I've been back, and I respect what you said, Dr. Smith, but I just want to be very clear on this one. I don't think I've ever said this before. I expect these 3 programs to roll out in October. If within the next 48 hours people think that's going to be problematic, I expect them to identify ways to roll these programs out in October. I think it's been 4 years now since we've been in this integration effort. We all understood that there was going to be a lot of challenge in doing that. I think people have been patient, and I think the time for patience has come and gone. Just to be clear, I didn't get up on the wrong side of bed today. It's not that I've got, it just was like we keep saying we're on the way, and it's time to no longer say we're on the way. It's time to say we are there, we are doing the work is getting done. Don't discount the complexity, but as you were kind enough to note, Ms. Tully's, this board has been very supportive on this. This is not a place where we've had to persuade colleagues of the importance of investing time or energy or resources. So I'm just going to let it go at that. My hope and expectation is that October means October. Meanwhile, how are we doing on mobile crisis teams and the PERT teams?
We've not been able to hire for PERT. We have been able to hire for mobile crisis. We're up to 10 staff.
Would you remind everybody what...
Psychiatric emergency response teams.
Thanks. And they do what again, just so everybody knows?
They would go side by side with law enforcement. That's an innovation project, and that has been a difficult area to hire. We've interviewed a lot of staff. Mobile crisis is up now to 10, and I know that we have several people who are interested in volunteering to be on call, which is the way that we'll be handling evenings, nights, and weekends with an on-call process. We've worked very closely with labor relations on this. What we're seeing is very high demand for mobile crisis, and in a number of different ways. The law enforcement agencies have been working closely with the team, but we're also seeing more and more community calls. Most of the calls that we receive from the community are not about a crisis. They're really about information and how to get connected to services, and we may refer them to NAMI. We may tell them to come into urgent care. It really depends on the needs.
Thank you. Before I turn to Supervisor Ellenberg, who I think would like to clarify a couple of points. So I'm sure it's a gross oversimplification on my part, but I think of mobile crisis teams as being essentially on standby to go where the problem is when the problem arises. And I think of the PERT program as being folks who are embedded essentially with law enforcement.
Yes.
We've been talking about the PERT teams for, I think, at least a couple of years now.
Yes, we have.
And so the question is the challenge with respect to hiring such that we ought to just say, you know what, this isn't a model that's going to work in Santa Clara County?
We are having that conversation. We've not made a decision on that. What's going on currently is the law enforcement agencies call us, and we have staff that are working directly with them, and that's been working pretty well with all the different law enforcement agencies. That may be what we have to do, is just use mobile crisis.
So we would use the mobile crisis teams rather than have the actual, what I'm calling, embedded staff.
Embedded staff.
Okay. I look forward to hearing more about that because, you know, at some point we just have to say if it's not going to go, it's not going to go. How are we going to meet the need in some other way so that we know that the need is at least being met, even if it's not with the ideal model that's out there. I've got some more, but I want to pause for a moment to go back to Supervisor Ellenberg, who had a clarifying question or comment.
Thank you. Since we are having an easier time hiring people for the mobile crisis unit, I presume that the jobs are not interchangeable. Can you tell me what the just big picture qualifications are of each role? Does psychiatric mean they are medical doctors?
No, they would be clinicians that would ride along with, be a partner with a law enforcement officer.
And the mobile crisis people
And
are not
mobile
clinicians?
crisis is across the county, working with all of the different law enforcement agencies. In both situations, these are clinicians, not physicians.
If we're getting lots of people for mobile crisis, are they not interested in PERT or not qualified?
We've not seen a lot of interest in PERT.
Interest, okay.
Very, very limited, actually.
Is it a salary issue, do you think?
Oh, same salary. It's not a salary issue. I just think it's the same situation that Supervisor Simidian was talking about and Dr. Smith was talking about. There are lots of places to be hired, and this is one that we're not seeing a lot of people demonstrate interest in.
Thank you. Headspace, which we've been talking about so long, it's now become renamed, and I believe it's now Alcove.
Yes, sir.
And do we pronounce it Alcove even though it's two L's?
Yes.
Okay. And as you know, I was an early booster of the concept, and this is another one that's been a struggle to stand up. And in this case, my understanding is that it's ironically more of a real estate issue than a personnel issue.
Yes.
Could you give us an update on where we are both with respect to the North County location and the San Jose location, please?
We have two locations. Fleet and Facility are working on the rent agreements. As of today, this week, the plan is that they'll be bringing those lease agreements to the board in September. And as soon as those leases are approved and signed, the next step will be securing the, oh gosh, I'm sorry. What is it? You have to get the plan. What do you have to get? I'm sorry.
A building permit?
The building permit, building permit. So then it's all of those pieces that will be both in the city of San Jose and in the city of Palo Alto. Fleet and Facility estimates that will be about a 3-month timeline unless we're able to move more quickly to get those permits. And as soon as the permits are in place, the facilities themselves, we've already done lots and lots of work. The facilities themselves, they'll be putting everything in place to open up the 2 alcove sites. I know in our earlier conversations about this right now, what the estimate is because of the time for the permits is about June, beginning of July, for both of the sites. So that's where we are.
What happens in June or July again?
We open the doors of these wonderful clinics.
It sounded like you're anticipating that both leases will be ready in September.
That is my understanding.
Okay. Could I ask that we do everything humanly possible to make sure that both leases are before our board, and with the understanding that then we're still 10 months away from being able to serve somebody, as I get it. Okay.
9 months.
And for those who are not familiar with the programs, my short version is it's a somewhat more forward-looking model for serving young people with engagement by the young people in the provision of the services and the description and selection of services. Is that a fair summary?
Yes.
Okay, thanks. Well, those were all tough, so let me give you an easier one. What are your thoughts about AOT and Laura's Law, and given the questions and the comments that we've gotten from folks who are here, and in all seriousness, because this is a tough one, you know, what I've heard, I think, in the past from staff is that there are some good things about AOT that we might do and stand up without some of the things that are more problematic. That's my short version of what I think I've heard over the last 2 years. Is that close? And what are your thoughts?
Close. I think as we stand up ACT, FACT, and Intensive FSP, which are programs the county has not had, and we combine that with the outreach teams and very much want to line up all of the outreach teams, I feel like we'll have a very robust system, and the goal would be to get people into the appropriate level of care. We anticipate, Supervisor Simitian, that there will be hundreds of people who need this level of care, who may be homeless or bouncing around in emergency psych. And I think what we need to do is fully implement these new programs. We have great providers who'll be working on that. We have great staff that will be working on that, and evaluate the successes we have with these new programs. That would be my recommendation.
How soon do you think we can realistically and reasonably sort of stop and take stock and say how this is going?
Well, as I offered a little bit ago to Supervisor Ellenberg, I think we'll do quarterly reports, and let's see what the outcomes look like.
I am wondering if there would be value in perhaps sort of, in addition to, and I don't mean to diminish the importance of sort of regular check-ins on a quarterly basis, but in addition to those routine reports, if you will, if we might take some time somewhere in the March, April, May, June period to sort of stop and ask ourselves in a formal and public way how this has been working, and involve various community stakeholders in that conversation in some way. Can I ask you to think about how we might do that, and perhaps come back with a recommendation to our office, and we'll talk about what that might look like. But I think I want to know what clients think, I want to know what providers think, I want to know what our own professional staff think after we've been at this for, I don't know, whatever, 6 to 9 months. So in addition, as I say, to quarterly reports, which I think are good, both in the near term and to Supervisor Ellenberg's queries earlier, longer term, so we stay on it, I do think that there's going to be a point where we need to sort of stop and say, okay, we're pleased we did roll out these programs, but, you know, how are we doing and what are they giving us and perhaps what they're not. And next question is, could you talk to us a little bit about call centers and what are the challenges or problem areas, and, you know, a little bit more about a realistic assessment of solving those. Ms. Tully, I'm not sure, I know Dr. Smith and some of the senior staff know, Supervisor Chavez and I spent a lot of time at the same dais talking about the call centers in connection with child abuse and neglect reporting, where Supervisor Ellenberg, I'm not sure if you know, the response rate was 59% half a dozen years ago, and to everybody's credit, while it took longer than we would all have liked, ultimately those numbers got up to 97, 98, 99%. Good. Tell us a little bit about the situation here, if you could, please.
So we have two things. We have a mental health call center, and we have Gateway, which is a substance use call center. We've brought in a year ago the top consulting firm in the country in our field to really look at same-day access call centers, how we can streamline that work. And Bruce Copley now is responsible, working really closely with the staff. We're working with a Cisco product so that we'll be able to have something electronic across our whole system, so we'll have a much better sense of where there's capacity, where there's not capacity. We have not had an electronic system to support the call center function, so that's one piece that we're working on. We've also identified a number of activities that the mental health call center was responsible for, and we're pulling many of those out and putting them into our utilization management area. So when you pick up a phone and someone calls at the call center, the staff there to do a quick screening, determine what somebody needs and connect them to the appropriate services. And we're slowly but surely cleaning out all of those other responsibilities that they've had in the past. So it's much more just a straight up call center.
Anything that you need or that we should be talking about in terms of either staffing or resources? Not to put you on the spot, but I see Dr. Smith's microphone is on. I don't know if it's on this. He's quickly turning it off. Okay, but
you know, at this point, Supervisor, I don't know that there's something I would request of you today. We've got a pretty good implementation plan, and I could certainly send an off agenda about what's working well in those areas that we need to, where there's opportunities for improvement.
okay. Thank you. Oh, that's very helpful. Supervisor Ellenberg, anything else before I ask for a motion to receive the report? All right. Ms. Tully, is anything else before we move on to the next item?
No, that's fine. Thank you very much.
We do have one card, actually, and let me take that. Mr. Largent, I think I have a card from you. We've handled public comment previously, but if you want to speak on this item, I want to make sure we give you that opportunity. And please come up to the microphone.
Thank you. I appreciate that, Joe. I was running a little behind.
That's okay. If we could, but we are going to knock it down to 1 minute and 30 seconds, just because that's what we gave everybody else. If we
I could do that.
Thank
I
you.
could do that. Great. Thanks you,
a minute.
everybody. So we have one clinician for every 200,000 people in our county. Is that the numbers right there? If there's only 10 people? Maybe I'm a little confused. We had a call out at San Jose City Hall that took 1 hour and 15 minutes for the clinicians to show up. I don't know these people personally. I don't think they did a very good job communicating with Armando on the roof. I don't think they had anything in common with Armando. I think they just pissed him off. And this is on YouTube, okay? I'm very frustrated with our behavioral health system. And please go on there and just watch it. Watch how the clinicians interacted. Watch how law enforcement did it. And the best part, actually, I'm sorry, it's the worst part, is when they cut out and left him on the roof. Okay, law enforcement is giving up on these people now, Tony, so you understand that. They don't care about them. So the people you're sending out, when they give up, they should never give up. They should have been there till I got that man down at 4:30 in the morning. They should not have left him up there. And the videos I put up there are a man ready to jump off a roof at about 3:30. I was terrified. Sean Cartwright was down there waiting down near the bottom. The system failed this man. I don't know where he's at right now either, and I would love for our county to figure this out. 27 calls to the suicide hotline. Nobody did anything. 220 calls to 911. That's a failure. Thank you.
Anything else on that item before we make the motion to receive the report, which has been made by Supervisor Ellenberg? I will second that, and without objection, the report is received. Thank you all who are here to speak to that item today. That takes us to the next item, which is item number 6, and that is the report from the County of Santa Clara Health System relating to the Section 1115 Medicaid waiver known as Medi-Cal 2020.
Yes. And good afternoon, Mr. Chair and Supervisor. I have with me today is Erica Murray, who's President and CEO of the California Association of Public Hospitals, who will do this presentation along with me, as well as Bert Margolin, who you're very familiar with in terms of a federal lobbyist. It is a very technical term, 1115 waivers, but I think it's so important for us to really get a better understanding of why they're so important. So one of the things that we did for you, and I want to thank Amy, Carter, and the policy team and all the department heads, is we provided a very comprehensive report, 29-page report. I know that was quite a bit of reading, with a very selective data points, so that way you get a sense of the movement in terms of our journey through this waiver process. And then we put it into the context, which is pre-ACA and post-ACA, which is the same framework we use for our community clinic report. So that way, as a governing board, you get a sense in terms of not only where we started, how far we've come, but then obviously how much more we need to do. And again, this is a pre and post reform, so I'll briefly go through that PowerPoint presentation right now. The waivers, there's been 2 of them during this period.
Forgive the interruption, Mr. Sonny, I apologize, but for everybody, this is a process that involves waiver application by the state.
By the state of California.
To the federal government.
To the federal government.
Which I know you're going to tell us about in a minute, but I do want to just sort of ask everybody to underscore the county's role in this exercise, sure, because there is one, and it can, I think, easily get lost in the federal-state conversation if we don't stay focused on that. So again, forgive me, I'll try and lean back now.
Yes, and we'll give a little bit of background for
Thanks.
that as well. I know it's in the written report, but I think for the general public, I think it's important. You're absolutely right. The 2010 to 2015 waiver is as what we call bridge to reform. That was used by the Obama administration after the national health reform was passed. And that particular waiver was used strategically by the federal government and the state of California to advance some of the coverage expansions that were included under national health reform. We'll go over some of the detail. And then the 2015 to 2020 period was called Medi-Cal 2020, so that way those are the 2 distinct periods. And then we're going to cover a little bit of what to expect in terms of looking ahead, what we're calling Transformation 2025. So that will present the overall perspective here. Next slide. Now, before reform, there were a lot of concerns in this county about Valley Medical Center and whether it was going to be ready or not for the competitive markets that were going to be emerging under national health reform. And as you can see here in some of the local headlines, this is selective in 2010 and 2012, there were a lot of questions about whether VMC was going to be ready in terms of meeting the challenge of not only having insurance reforms and a new marketplace emerge, but then also be able to meet the demands primarily by patients who are going to be looking for better access and obviously better service and ultimately better care. We're happy to reform. Obviously, you walked through some of the journey with us after in terms of the post-reform, just to give you a pre and post. In 2015 and 2019, the headlines are very different about VMC. And I think it's so important to keep that in mind that not only in 2017 and 2018 and 2019, the recognition that's flowing as a result of the very hard work that our employees, our stakeholders, and obviously our leadership and management, with the leadership and support of Dr. Smith and all of our board members, we have been able to make great strides in terms of not only our progress under ACA, National Health Reform, but also to put us in a position to serve even more people and better with the recent acquisition of St. Louis and O'Connor. So we're going to go a little bit in terms of the detail of what took place during this period, but it's really the unfolding of a very good story during this period of time. Next slide. Now, waivers as federal, state, and county partnerships. You're right, the states have to apply for an 1115 waiver. It is a power and authority granted to the Secretary, the Federal Secretary of Health and Human Services, to innovate and experiment with the Medicaid program, which is Medi-Cal in the state of California, and implement some things as long as they meet very specific requirements. So one of the things that in 2010 and 2015, the Bridge to Reform waiver obviously included some of the early expansion of coverage to the populations that ultimately were going to become eligible for 2014 under the Medi-Cal expansion. And you see that moving from left to right in terms of the Bridge to Reform, early ACA expansion. And here locally, we had our local coverage initiative, which was funded partially with local funds, matched with federal funds. And the whole idea was that by providing early coverage and expanding some of the care to these early populations, that we would make incremental steps towards universal coverage. And of course, we would make the transition from that population seamlessly into Medi-Cal expansion and the local exchanges or state exchanges, which in our state is obviously Cover California. The Medi-Cal plan 2015 and 2020, it was intended to have the evolution of managed care, which we're calling 2.0, and advance what we call AAA plus, which is better care, better service, leading to ultimately better health. And then, of course, there were some very specific projects and initiatives, which will give you a report very briefly in terms of prime and whole person care, which is WPC 1.0, that will drive some of the better value in terms of the proposition to the federal and state governments, and of course, ultimately lead to safe, effective, and efficient care. And of course, one of the things we're going to be talking about is what happens after 2020, which we're calling as the next generation. And what we're proposing is to advance the transformational effort here of our local health system in terms of whole communities on whole person care towards our vision of better health for all. Next slide. So under the Bridge to Reform, if you remember, this is 2010, 2015, we had 19,000 residents enroll early in our Santa Clara County local coverage initiative. And of course, they seamlessly moved into Medi-Cal very quickly. In the care delivery reform, we have what we call DSRIP, which is Delivery System Reform Incentive Pool, which allowed VMC to focus not only in improving primary care capacity, but also early reforms in decreasing inappropriate emergency department use among target populations, in this case the homeless, and of course improving our safety and quality of what we do in our facilities, and in this case leading to a substantial increase in terms of sepsis and compliance, which is hospital-acquired infections, moving from 19% to 68% during that period of time. Medi-Cal 2020, which is the period where we're in right now, we took a hard look based on our experience of the early 5 years of national health reform. We recognized that there were still some foundational things that we needed to do, things that we need to do regardless of whether we have waivers or not. That's what we call foundational things. You'll see a snapshot here of all those activities and major initiatives that we identified. But ultimately, there was also this transformational vision of having the patients in the middle of our care delivery system. And as you know, many times, we just finished talking about in terms of the challenge of health professionals many times we have to design systems around the health professionals and around the availability of those professionals and all these other things. And our transformational effort is really to put the person and the patient in the middle of what we do. And that's what we consider for us in terms of our transformation process. Ultimately, all these things, our goal is to have better health. And it is particularly challenging here because we're already one of the healthiest counties as a result of prior investments and a lot of socioeconomic conditions and factors that go into it. But in our direct way, we obviously reduce drastically the number of uninsured. And we know by the science and the evidence that when people have insurance coverage, they have better access, and ultimately better access leads to better health. So as you can see, there was a drastic drop, which also happened in other communities across the state as well as America, where if you did certain things to drop the uninsured, you actually have better outcomes. Public health led in many ways our community engagement process, which was led by our board, but also in terms of the work by public health professionals to get a better understanding of our communities here in Santa Clara County by doing in-depth needs assessments. And here we have a few of those, which the Vietnamese American Health Assessment, as well as the African ancestry research, as well as the LGBTQ, Latino health assessments, there are a variety of these. And then those leading to very specific actions supported and funded by the Board of Supervisors to improve access and outcomes within those communities. In terms of better care, this is, again, providing better care under AAA+. We're striving to provide services in the most appropriate settings by expanding health screenings. I mean, it's one thing to get coverage, and that's good. It's a good thing to have insurance, but ultimately what we're looking to do is better access, and there's a whole effort on board to make sure that people are getting timely preventive screenings, whether it be for behavioral health assessments, diabetes prevention, a variety of other kinds of screenings, and then, of course, having better integration and coordination of the care treatment system and ultimately the recovery and rehabilitation systems that we have. And we see some of the early results here in terms of that strategy, in terms of decreasing the rates of what we track in the health field, the all-cost 30-day readmission rates, the inappropriate utilization of our inpatient hospital services, as well as a result of not having people stay there longer, reduction of hospital-acquired infections. In terms of better service, and this is one of the areas that you have particularly focused on, and obviously our department heads report on a regular basis, better service is decreasing our wait times. This is an area that we looked at not only at behavioral health, but also VMC, at our community clinics, as well as our other programs, and you can see some of the early results here. We believe by obviously providing better service, lower wait times will improve the patient satisfaction scores and the patient experience, and then ultimately all those things will lead to better health. Specifically here, on the last part of this slide is some of the things that obviously Tony and her team are doing in terms of the crisis text line that's driving some of the access and some of the better service, as well as the Gender Health Center and our new downtown health facility. Better value for us means that we take responsibility for the total care and the total cost of specific populations. In healthcare, we track them by what we call covered lives. These are managed care enrollees that are assigned to our system on a full risk, meaning that we're responsible for their total care. And as you can see here, we started with a baseline of 112,701 pre-Medi-Cal expansion. This is in December 2013. If you recall, the state of California expanded Medi-Cal in January 2014. And since then, we have increased tremendously the number of covered lives that are assigned to our health system. That has led to obviously a huge drop in unsponsored patients coming into our facilities, improves not only the better service and care for them, but also in terms of the revenue picture for VMC. And as you know, one of the unfolding stories that we have here reported on a regular basis is Valley Health Plan, who for the first time offered individual insurance coverage under the state exchange Cover California. And of course, they started from zero, and they have now 17,000 lives. What's even more significant about that is that they're the affordable plan, and I know Supervisor Simitian, that's one of your top priorities, to be able to have the most affordable option for residents, even when they do work and obviously have resources. We've done quite a lot of investments in terms of the infrastructure. You mentioned a few of those already in other topics, but you're very familiar with EPIC. Our teams, and just most recently, Paul and Sue and others will report in terms of bringing EPIC to St. Louis and O'Connor, but our teams have turned that tool and technology into better care and better service and better value, and that's recognized by what we call HIMSS Analytics Stage 7 here, which is the industry recognition for health systems that actually optimized technology to improve the care and service for populations. And of course, we talk about some of the efficient use of resources in the specialty pharmacy program, as well as using and helping and working with our employees. We added, normally people talk of triple aim, and we call it triple aim plus because we know all these things are very difficult, hard, complicated, especially when you're dealing with a specialized system like ours, very complex. And so one of the things that we set ourselves apart from other public entities as well as private health systems is we have a very specific core objective around growth, learning, and development. And we use that banner to really indicate and signal of how we're supposed to accomplish this. It's not only the what, but also how. And what we're talking about under this is obviously engaging our workforce much better, whether it be through unit-based teams. And this is something that it's unfolding, great story. We report that monthly. We're up to more than 122 UBT projects completed across the county. Now it's in other departments and not just in the health system. You've heard, obviously, Dr. Smith in terms of the updates. We've used the CLTs, the Center for Leadership Transformation, to really roll out transformational projects across our health system to the tune of 58 to date, and that's quite extensively dealing with a variety of different issues and gaps and opportunities for improvement. And then, of course, as part of our T2020 efforts, our Transformation 20 efforts, we've engaged over 350 staff in all these T2020 projects. So looking ahead, obviously there's a lot of concern, and Erica will touch on some of this in terms of the outlook in terms of the state and federal governments. But one of the things that under the leadership of Dr. Smith, that we as a health system have put ourselves as a top priority is that whether we get a little waiver or a big waiver or somewhere in between, Transformation 2025 needs to continue. This is a journey that's delivering better care and better service to residents in Santa Clara County, and obviously with your leadership and investment in helping us acquire other community assets like community hospitals, we're looking to integrate and improve what we're core mandated to do, plus the things that we think are necessary to maintain a healthcare safety net here for residents in Santa Clara County, whether it be in custody health and behavioral health, or in the Paul Health Center, or St. Louis, or O'Connor, or obviously at VMC. We, as mentioned, we just recently expanded EPIC, and we expect to have similar results in terms of improvements in quality and safety and revenues in those facilities, although that's going to take us some time, as also happened in VMC. We're looking to engage the state in determining what's going to be the future of Medi-Cal, because Medi-Cal is so important to us, and Bert obviously has a lot of experience in that regard, but more importantly, this is something that we see a shared destiny, not only in terms of the state and us having this partnership to ensure that the significant portion of the population that relies on public insurance, Medi-Cal, continues to have better care and better access in our communities. And then, of course, looking for opportunities to advance the innovation, which we call WPC 2.0, which for us is our transformational effort of having a full transformation towards the whole person and whole communities. Our vision is very simple. We want every resident in our community to have great education, to have access to open green spaces, to have readily available and convenient facilities in terms of health and childhood development and all these other things, to have clean air, clean soil, all these things that are important for public health. And then, of course, that's something that we aspire to deliver not just for the most vulnerable, for all 2 million residents in our county. And that's what we consider to be our core public health vision of better health for all. And of course, the last slide here is that we want to do it with a sense of pride that goes with working for a government that invests in people, that makes people a top priority, and of course makes health a top priority in terms of program services, and therefore we have the marketing strategy of Go Public, and that available to answer any questions you might have at this point, but Erica also has another presentation of this.
All right, in light of time, Ms. Ellenberg, I'm going to go to it's Ms. Murray, yes. And Mr. Margolin, are you part and parcel of this conversation as well? All right, so please.
Good afternoon, and nice to see you. Thank you, President Smidian, Supervisor Ellenberg, Dr. Smith. Thank you, Renee. I appreciate the chance to be here. I am the President and CEO of the California Association of Public Hospitals and Healthcare Systems. We represent 21 public healthcare systems across California. California is the only state in the country that has an association specifically for its public hospitals, and we're very proud of that. We represent mostly county-owned and operated facilities. We call them public healthcare systems because you all well know they are not just hospitals. They span the comprehensive range of services. We also represent the 5 University of California medical centers. And as Renee alluded to, a waiver, an 1115 waiver, is really, it's a terrible name for what is essentially a deal between a state and the federal government. Because Medicaid is a state-federal program, it requires negotiation between the two to waive certain components in exchange for advancing policy ideals. And CAPH, amongst other activities, is the organization on behalf of our members. We work very closely with administrative, executive, and clinical leaders to develop and negotiate, and then with our Safety Net Institute, help members implement the 1115 waiver programs that are really designed to catalyze delivery system transformation. So since about 2005, we have been doing just that in designing these 1115 5-year waiver programs that have gotten larger and more ambitious over time. Waivers represent about, on average, 20% of all revenue that comes into a public healthcare system. So they are an extremely important source of financing for public healthcare systems. And the role, of course, of counties and public healthcare systems in this work is to put up the non-federal share. Of course, Medicaid requires a federal share and a non-federal share. And in California, the state largely delegates that responsibility for Medi-Cal to counties and public healthcare systems. So we're providing the non-federal share, and of course, the public healthcare systems are also doing the work of whatever it is that we're committing to. So although it's a state-federal negotiation, by virtue of providing the non-federal share, counties and public healthcare systems have a unique seat at the table. There is a benefit on some level of providing that non-federal share because it gives us the opportunity to influence and oftentimes even design ourselves and then negotiate with the federal government what those waivers and deals will be. So I think it's fairly common knowledge that California's Medicaid rates are low. California is often cited as providing closest to the bottom in terms of rates. And even though, of course, with the Affordable Care Act and the Medi-Cal expansion in California, the program has grown significantly, the state's contribution to the Medi-Cal program has largely maintained at 19%, which reflects a huge increase in federal contribution. You'll recall that the Medi-Cal population that became eligible in 2014 started at 100% of federal and then is now down to 90%. So the feds are putting in more, and counties and public healthcare systems, as well as other providers, are putting in more. But the state's contribution has remained largely flat. At the same time, public healthcare systems, because Medi-Cal rates are so low and because public healthcare systems primarily serve a Medi-Cal and uninsured population, even as our revenues grow, our costs also grow, and our revenues never hit our costs. And so because we finance most of the payments, we call it self-financing, because we self-finance, that gap also grows between our costs and our revenues. And so inherent in a self-financing structure is that deficit that continues to grow. It's just important to note because it's an ongoing challenge that is a manifestation of self-financing. Go ahead. Yep. So it's important to note that actually 2 waivers expire next year in December of 2020. Our 1115 waiver, which covers healthcare services, as well as the specialty mental health waiver, which governs a lot of what was covered in the earlier discussion on behavioral health services. And the 2 waivers have been aligned so that they both expire at the same time, which really gives us an opportunity to think holistically about what's possible in improving the comprehensive delivery system for patients in need in localities such as this. So being in the 4th year of a waiver, this is normally when CAPH does what we do. We work with members to consider what we've accomplished, and you can see the incredible work that has happened, not solely as a result of 1115 waivers, but with the catalyst of significant dollars from the federal government that were tied to performance-based payments for Santa Clara. The difference this time is that CMS, the Centers for Medicare and Medicaid Services, and the federal government has indicated that they are not willing to entertain a renewal of an 1115 waiver in the way that they have in the past. They have concerns about the financing structure of the way that 1115 waivers are structured. That's the bad news. The good news is that they have indicated already a significant willingness to essentially swap out 1115 waiver pilot funding for supplemental payments through Medi-Cal managed care. So while the vehicle may change, we believe there's a significant opportunity to continue doing the kind of work we're doing. So the federal government will continue to provide significant payments to supplement low Medi-Cal rates, and we will continue to design those supplemental payments in ways that tie those dollars to performance-based work. So there'll be a shift in vehicle, but we believe it will simply be a shift.
Forgive the interruption.
No, this is complicated.
There's a phrase there that I think might be significant. Supplemental payments, I heard.
Yes.
Key phrase, through managed care.
Yes.
That's a change, yes?
It is a change.
And what does that mean, and what are the implications of whatever it means, please?
It means that instead of waiver payments being financed directly from counties and public healthcare systems and then coming back directly to counties and public healthcare systems, those dollars would flow through Medi-Cal managed care plans. And it's a significant change because it aligns, we believe, with where Governor Newsom is looking to, in how he's looking to invest in Medi-Cal managed care. Because there has been such growth in enrollment in Medi-Cal over the years, there's real opportunity to improve the quality and efficiency and effectiveness of Medi-Cal managed care. And so these dollars would flow through managed care plans, but come to public healthcare systems, mostly tied to performance-based metrics that we will design.
Forgive me, but the Medi-Cal managed care provider in our county is the Santa Clara Family Health Plan.
And Anthem Blue Cross, the private. We have
Yes.
a two-plan model. We have a two-plan model that has one private, Anthem Blue Cross, and then the public, local initiative was Family Health Plan.
And again, forgive me, but neither of those is, quote, the county of Santa Clara.
Correct.
So should I be concerned that funds that previously were headed to the county are now headed to someplace else?
I'll take that.
There you go, Ms. Moore.
Yes.
Yes, big yes.
Thank you. That, I felt pretty sure when I saw through managed care, I should be asking what the implications were. And so, in addition to the yes, could we maybe have a moment here? And I, again, apologize because I know you were mid-presentation, but
That's
it seemed to
fine.
me this was an important moment. The implications for us then are what?
Well, first of all, thank you. I've been here for 10 years, started off at the very beginning saying we should be concerned. You're the first board member who's actually said I'm concerned. That's good. Made some progress.
Once a decade is not a bad average, so there you go.
The issue is that the way that two-planned counties were created, not all counties are two-planned counties, there was this fantasy belief that having a private sector and a public sector health plan, quote, competing with each other for Medi-Cal business was going to make Medi-Cal cheaper when the state in the late 60s forced most Medi-Cal beneficiaries into a managed health care plan, forced them into health plans. That didn't turn out to be correct. What turned out to be correct is most of the private sector plans like Anthem Blue Cross in this county, others throughout the other 12 counties that have two-plan models, really just dabbled in the field, did it sort of as their social contribution, had very small numbers of lives, and pretty much the public sector health plan did all of the yeoman's work. In this county, for reasons that are beyond me, when that public health plan structure was created, the administration in Health and Human Services believed that Medi-Cal managed care would fail, and they wanted to create a legal structure that they could cleave off from the county and be done with. And so they created Family Health Plan as a separate entity with a separate set of priorities, separate employees, separate initiative. And that worked during a time period when the waiver worked through the county. Now that we're going to have a waiver that works through managed care, unless we're on the same page of the playbook 100%, the county will be spending additional monies and not being reimbursed by the supplemental Medi-Cal payments. Right now, today, as it stands with the current waiver, the county general fund subsidizes Family Health Plan by the tune of $20 million a year. I'm very, very concerned that that number will go up into the $100 million range with a new waiver unless we can get on the same page of the playbook. I finally got to say that.
Thank you. I think, at the risk of stating the obvious, to be continued. And I think, Ms. Ellenberg, I will anticipate that maybe as we see how things proceed, that topic is sort of a standalone conversation for our committee here. Ms. Murray, back to you if that's okay with Ms. Ellenberg. Back to you. Thank you. And again, thank you for accommodating the inquiry in real time.
Not a problem. If we go to the last, oh, here we go. You'll see that Dr. Smith has covered point 4 of this slide, which is that this shift to managed care will require strong alignment at the local level and at the state level with Medi-Cal managed care plans. It also doesn't change the fundamental structure of self-financing, so it does not yet address this structural deficit. And part of what we are engaged with the Department of Healthcare Services and the new Secretary Galley, who comes from the county world, and so understands and really appreciates all of these issues, are the challenges associated with self-financing. I did want to alert you to some of the things that we are anticipating including in these new payments. Every 5 years, as we develop these, what were waivers and will now be supplemental managed care payments, we ask ourselves, how much have we accomplished, and what more is needed? And where can we go to create a more patient-centered, effective system? And I would posit that over the past decade or even 15 years, we've made incredible strides in the improvement of delivery system and access and patient services. There's still more work to be done on that front, but the thing that we have not been able to tackle up to now is really around cost. And so we are taking a hard look at the work that we're doing to see if there are ways to truly become more cost effective, knowing that, again, if your revenues are never going to meet your costs, one of the things we need to do is see if we can start to to bend that cost curve. It won't be easy, and we're not expecting it to be easy. We've never had an easy a waiver. They are intentionally designed to I like to say, to flirt between ambitious and impossible, to keep us kicking ourselves in the pants to do better work. But I did want to alert you that is one of the areas that we are considering adding to these incentive payments to create that catalyst. And then, as mentioned, with the expiration of the specialty mental health waiver, we're also looking to see if there are possibilities with the alignment of the timing, if there are opportunities to align some of the work so that, again, patients can receive truly holistic care.
Thank you very much. Supervisor Ellenberg?
Thanks. I have a question for you and then a number for Renee. And focusing on the simultaneous expirations of the 1115 waiver and the mental health 1915B, what do you expect will be the impact on integrated health and behavioral health planning for the next waivers?
My answer to that question is the answer that I almost always give, which will be it will vary. It will vary by county depending on the structure and situation right here at home. Santa Clara is extremely well positioned to think about opportunities holistically because of the structure of the health and hospital system and the inclusion of behavioral health with physical health already as part of the organization. There are other counties where healthcare and behavioral health are very siloed. And while whole person care helped begin those conversations, they're really at it's a nascent phase. Mm-hmm. I think that there are real opportunities here to think about how to leverage the structure and the shared goals of improved patient care to really design a vision for what's possible over the next 5 years in ways that can think about both funding sources.
Thank you.
Yes, and just to add that particular piece, obviously because not only our composition and our strategy here, but we fundamentally believe in holistic care. And so we need a structure that can help us develop, implement, and learn from integrated care models. We need health plan partners that are actually reinvesting dollars back into the care system for support services for our patients. Some of those things may not necessarily be more medical care. Some of those things may not necessarily be more therapeutical care. As you know, some of them involves better housing. Some of it involves better food and transportation. So we do believe in an integrated model. And we're looking for opportunities to advance those, whether it be through waivers or other kinds of set of solutions.
I would say that some of it also involves family leave and child care policies.
Absolutely.
Dr. Smith?
I'd like to jump in to reemphasize I think, as Erica pointed out, we're sort of, as a county, in a unique position because of the forward-thinking aspect that the board has taken in the past. Things that put us in a unique position to possibly take advantage of the new waiver in a very positive way, or to become a demonstration county. As Erica pointed out, we have an integration that's strong between medical health and mental health and substance abuse already, but we shouldn't forget that we also have a strong relationship between medical health and public health. And even though Dr. Cody sometimes looks at me crazy about how they're integrated, the reality is that public health is what cures medical and mental health. In addition to that, in terms of the social...
No pressure on her, though, right?
No pressure.
Okay.
I keep telling her every time I meet her that everything's public health, and she looks at me cross-eyed. But it's true. And the other thing is the board is invested in getting the approval of Measure A, which is, and creating OSH, which is a housing initiative that will help us dramatically with the program to circle patients in care. In addition to that, we were in our demonstration project, basically the county that focused on whole person care, so we have the experience of using these services in a wraparound function for our high utilizer population called the HUMs. And in addition to that, as Supervisor Ellenberg points out, we're now moving a major initiative at the board level to refocus ourselves on children, schools, and child care, and we have one of the most innovative first fives around. So we really have all the raw materials to put together a wham-bang solution here, but there's a lot of moving parts.
Thank you. Supervisor Ellenberg, anything else before I go to I have one more question myself.
Okay, I have some additional comments, but if Bert is going to speak as well, I think I might hold them.
Sure. Let me do this. If I may, let me go back to Ms. Murray. I have a question for you, and if it's one you want to punt on, I'll ask Dr. Smith. You'll see why in a minute. And then go to Mr. Margol and then come back. Is that okay?
Thank you.
Ms. Murray, I think you mentioned you have 20-plus members in the association, and as you play a role in these negotiations, I know one of the challenges of having an association of that size and diversity is that sometimes not all of the members' interests align. So that puts you in a challenging position because you've got to reconcile different interests. Are there some, to you perhaps, self-evident or obvious tensions built in there between or among different members of the association? I'm trying to think through sort of what different forces are going to come into play as these negotiations proceed. Was that tactful enough?
It's a wonderful question. It's the challenge of my job. There are many similarities across our membership in terms of a commitment to the Medi-Cal population, the structure of and our ability to employ physicians. That sets us apart. What also sets us apart from other, even safety net systems, is that we are systems, and that other hospitals, while they may have affiliations or relationships with outpatient care, we have structurally soup to nuts, and every single one of our members includes primary care, specialty care. So we're able to think in a system-like way, and we don't have the incentive to fill beds the way other hospitals often do. That said, CAPH represents San Mateo Medical Center, which is one of our smallest, and the Los Angeles Department of Health Services, and the 4 hospitals and the enormous outpatient network that it includes. So there are size differences, there are geographic differences, there are of course differences between counties and the University of California, which has a largely different business model with a heavy emphasis on tertiary and quaternary services. Our goal is always to try to find ways. It may not, each incentive program or each, I like to say, puzzle piece may not serve or interest each member equally, but what we design is an entire puzzle that drives delivery system transformation and ensures financial stability for the whole membership.
Okay, Mr. Margolin.
Good afternoon. Renee and Erica have really covered most of the landscape here. What I want to do is underscore a few of the points that Erica recently made and provide some additional national context about the waiver environment in Washington, the agency that has to approve the waiver, and what's going on at a national level. So the first point I would make that I want to underscore when Erica talked about the role that counties play in the financing of the waiver, it's really important to emphasize that because as a legal matter, this is, and Erica referred to it as a deal, it is a state-federal deal. And in all the waiver negotiations that Renee and Erica and I have been involved in, and we've been involved in several, there's always a point in time, it always happens, where the federal government and the state want to go into a room by themselves to sort of work this out, and the county concerns are sort of pesky and maybe not something they want to prioritize, but we are the entity that finances the non-federal share, that puts up that non-federal share, and we have standing by virtue of that, and just it's important for all of us to kind of keep that in mind, because at some point in the process, we'll have to assert that. We always do in these waiver negotiations. So the national context. CMS is the agency, federal agency that we have to negotiate with. It's run by Seema Verma, an ally of Governor Pence. They currently have 1115 waivers in 40 states. So this is, again, happening. Waivers are all over the country. There are 18 states currently that are dealing with potential new waivers or waiver renewals. Again, these sometimes take months or years, these negotiations. So they're not all coming to a head at the same moment in time. But this agency, CMS, has lots of transactions going on. What we're doing is not occurring in isolation, and CMS is very conscious of the precedents they establish, things they do for another state, they may be forced to do for this second state or third state, and it applies to approvals and rejections. The Trump administration, which, as we all know, on the ACA, has been pretty consistent in its attitude and perspective. It's all been in one direction and largely negative. When it comes to waivers, it hasn't been one direction. There's been both positive and negative developments. We all know on the negative side that we've had a number of waivers advanced that involve work requirements under Medicaid, and we've had waivers that have been advanced that would make coverage expansion more challenging, more difficult. These are options that have been pursued almost exclusively by states that have not been supportive of the ACA. Again, it's an option. A waiver is an option. None of these issues are going to affect California. Our waiver application obviously won't include any of this, but in states that want to move in this more negative direction, CMS has been open to that. At the same time, they've approved a number of waivers that have been more hopeful, more positive. They've approved a number of substance use disorder treatment provisions around the country to make those services more readily available. In Texas and Florida, they've approved in both states expansions of their safety net care pool, which is the fund of money used to help with services for the uninsured. They've grown those services in those states. And recently in North Carolina, this is of special interest to California, they've approved a waiver for North Carolina that includes something called the Health Opportunities Pilot Programs that are designed to address the social determinants of health and provide funding for and coordination of needs that go beyond the purely medical, transportation, housing, other issues, somewhat related to what we're doing here in California and our whole person care, and that was recently approved again by this CMS. So both positive and negative developments. When Erica talked before about the financing mechanism that is going to likely make our waiver this time a smaller waiver than we've had in the past, it is worth sort of emphasizing that again. This is a national policy. It's not directed to California. It's not something they've said we have to comply with because we're California. And this is a debate that's gone on really for 20, 25 years. Both Democrats and Republicans in Washington have debated this issue, and the buzzword, the term that's used is budget neutrality. That's the term that Erica was referring to. How much new federal money you can get is determined by whether or not OMB, the Office of Management and Budget, says you're budget neutral. And that calculation, it can be somewhat subjective, and it is connected to what's your base year, what's your inflation factor, what are your projections. And there's a school of thought that both Democratic and Republican administrations have held in the past that they need to be at the federal level more conservative about that. And in fact, the Trump administration across the country is implementing that. So that's why you're hearing talk of a smaller waiver, but we do have, as Erica talked about, this managed care component that we hope can fill in the gap. And the last comment that I would make about the dynamic here is that we're also hopeful about this waiver, even though it involves a somewhat awkward, certain to be at times somewhat tense federal, state, county negotiation. We're somewhat encouraged by the Newsom administration's commitment to health care. It's always important to emphasize that this administration is more committed to expanding access to health care than any administration since the creation of Medicaid. They've made it a higher tier, higher priority issue, and that's going to, we think, be helpful to us in this process. In terms of the state process, there's a stakeholder process. The state's already begun that with a meeting in July. There's going to be a second meeting in October, end of October. Erica may know more about this, but I think they're likely in late October to unveil their high-level concept paper that will give us our first real sense of how all the pieces fit together. And that will then lead into an extended stakeholder process and then negotiation with CMS. The last complication that I'll touch on that isn't normally as much a factor as it may be this time is that our waiver expires at the end of 2020. At the end of 2020, there's also a presidential election. We might find ourselves, the state of California, in a negotiation with one administration, and then along comes potentially a transition to another administration or not. We don't know. We can't predict or project. But that's one other complication that we all need to keep in the back of our minds as we go through this exercise, which is quite challenging. That's my report, Mr. Chairman.
Thank you very much. Ms. Ellenberg.
Thank you. Thank you all for the reports. This really is fascinating, and I appreciate getting this broad view of our health system evolution over the last number of years. It's clear to me that we are at a transition point in our health system in several areas that have been highlighted today. So as we move forward, I want to really push for us to think very broadly across these efforts to a place where we're not the third healthiest county in the state, but perhaps the healthiest county in the country. And so my vision for our healthcare system would include certainly broad universal access to care, a focus on preventative and early intervention services, particularly for kids and families, the integration of physical and behavioral health, a system that engages delivery service partners and community members collaboratively to improve outcomes and eliminate disparities, and of course, accountability for the quality and the value of our public investment in health. So all of that to say, in a future HHS report, I would like to see the timeline and major phases of this health system strategic planning effort, including how we're going to engage stakeholders beyond direct county stakeholders in this process.
Will do.
Thank you all.
Thank you. I have no additional questions. The only comment and requests I would make are I do look forward to following up Dr. Smith on the issue about what appears to be an increasingly important understanding and effort around the managed care players in the mix if the new world of waivers looks different than the old world. And I think that will probably require some focus, time, and effort here at the committee as well. So we'll follow up there. And the other thing which I prefaced all of this discussion with is to say I do want us to be sort of mindful, and I know our staff and our consulting teams are, and our association representatives are, but sort of mindful of what the county's role can and should be, and if there are opportunities for us to play a constructive role along the way. I don't kid myself that the world is waiting to hear what the county's HHC committee is thinking on this subject, but there may be opportunities for our board to weigh in and/or provide direction and/or for a check-in by staff. So please, let's just stay there. Dr. Smith?
Actually, maybe the world doesn't necessarily hold their breath about what you say, but what this committee has done over the years has made a huge impact at the state level and also made an impact at the federal level. So I wouldn't underestimate the committee's, efforts and effectiveness at setting policy.
All right. Well, then we will be doubly diligent in our work. All right. Thank you. All right. Thank you. Thank you. Thank you. And thank you. That takes us then to item number 7, which is the hospital integration report. And let me just ask, I think we had some comment from members of the public earlier under public comment that was clearly relevant to some of this, but let me just ask the clerk, do we have cards on this item at this point? Item 7, all right. Do we have folks who are here to speak to item 7? I'm just trying to be responsible about the calendar. Doesn't appear we do. Okay, we were apparently overly optimistically, I was anticipating a 4:30 end to this meeting. We do have a hard stop at 4:45. The good news for everybody at the dais is it means that there'll be limited time for questions on your various very brief reports when the time comes. But let's try and make sure that this continuing series of conversations about hospital integration gets the time and attention it needs before we go to that close. And who would like to begin? Who's presenting on this one?
Thank you, Supervisor Simitian. Supervisor Ellenberg. First of all, I think we all appreciate the fact that our first priority in this integration is the stabilization of the workforce. And I do want to thank the board and obviously Dr. Jeff Smith for their support. What we wanted to do is to give you an update on HealthLink. As you know, that is and has been one of our major milestones that we are working towards. This past Saturday at 4 a.m., we flipped the switch, and O'Connor, St. Louis, and DePaul Health Center are now on HealthLink. So I'm going to turn it over to Sue Clemens, who is our Director of IT and IS. Also present, of course, is with us is John Henley, St. Louis Hospital Executive, and Pat Ryan from O'Connor.
Welcome all, and thank you.
Sue.
Thank you. Good afternoon, supervisors and committee members. Thank you for the opportunity to talk about our HealthLink Go Live. We are live. As Paul had mentioned, on Saturday at 4 a.m., we flipped the switch and we went live on HealthLink at O'Connor in St. Louis. This was a 5-month endeavor. The next slide. I'm going to go quickly. What typically would take 12 to 18 months to do a project of this size and magnitude actually took us less than 6 months. Within that short time, we built new workflows, we tested new workflows, we implemented new policies, new procedures. We imported 1.3 million records from O'Connor and St. Louis of patient information. We trained over 2,000 new users, CTs, super users. We created 22 new interfaces, managed several different projects, amended many, many hardwares and software contracts. We installed over 2,000 end-user devices. That includes PCs, laptops, phones, workstations on wheels, badge readers, scanners, you name it, we put it out there. We created over 2,000 new accounts for our users. That was Active Directory accounts, single sign-on accounts, various application accounts. We installed a new network infrastructure, including a brand new wireless infrastructure, and we upgraded the cable at O'Connor. We built out HealthLink along with 62 other clinical applications. The HealthLink application scope for this project included inpatient, outpatient, the infusion center, wound clinic. We also went live with RevCycle, ED, surgery, and with all the nursing and provider workflows. We also implemented population health for our data analytics, My Health Online, and again, population health. Some key clinical core systems, as I mentioned, are up here as well. We also went live with all of our ancillary systems, including radiology, laboratory, and pharmacy. These are a few of the other systems that we went live with as well, including a brand new PAC system. We also went live with a new, we implemented Pyxis across the board for all 3 locations, cardiology, and other services. Before we get to go live, all of that was done in compliance with our CISO for security and privacy. We worked very close with our Chief Information Security Officer, our county counsel, as well as our Chief Privacy Officer and our Compliance Officer to make sure that all of these systems went in on our standards, as well as on our network infrastructure that has all the tools for privacy and security. So Go Live. Go Live started at 4 a.m. We had over 350 super users out there supporting the end users at O'Connor and St. Louis. We ran around in our orange vests so you could find us easily to answer any questions. We had a lot of staff from Valley Medical Center, from IT, from the vendor out there. We had 3 command centers, which is actually like an air traffic control center for all the issues, so we were tracking all of that. We also had 2 provider support centers, so we provided drop-in places both at O'Connor and St. Louis for the providers to come in and get direct help as well. Many, many tickets. This was taken a few days ago. We're well over 1,000 tickets, all of which are getting, anything that is high has been resolved quickly and swiftly through our rapid response. The Go Live's just the beginning. So we are on the verge now. We're on day 6. So the Go Live is just the beginning as we're pushing through, going through the change management as we're already optimizing the system. Dr. Tong, who could not be here today, did want me to pass on that the physicians are very pleased with the system. They're very excited to have access to data at their fingertips and are thankful and amazed at how wonderful the applications are working for them. So what we expected is what we expected. A lot of hardware issues, keeping in mind that not only did we just put an icon and have folks start working in HealthLink or Epic, we changed out all of their equipment. We changed out the way that they log on to computers. We changed out the way they did their radiology. We changed out a lot of things. And through it all, we expected some issues around printing, around security, but none of which that were unexpected that we couldn't handle. So what's next? We're keeping up on the issues, mostly around equipment, keeping the legacy systems up with the new county systems. We do still have the old systems up, and we will until the end of September. Printing errors and mapping, a lot of new equipment went out, so we're working through a lot of those. End user access, as I had mentioned. Workflow changes and training needs. We changed a lot of workflow for a lot of people when they went into HealthLink, a lot of policies, a lot of procedures. So we continue to work with the end users on that. Radiology modalities, equipment, and workflow, as I mentioned, we changed out the whole PAC system, so we're working through some of those issues. Conversion of legacy data was not ready at Go Live, so we did have to keep a lot of the legacy systems up, their old EMRs, in order to have access to data. And we have equipment needs. We've identified that we need a lot more workstations on wheels for the mobility of the clinicians. So as I said, we are just at the beginning stages, day 6. We continue to have the command center open, and we will continue to do so and have elbow support 24/7 for the next couple of weeks. We're already looking at optimizations and ways to enhance the workflow for the organizations. We're working on the conversion of the data, so we're continuously working to get the data into HealthLink and other systems. We are also continuing to install more more hardware, printers, more workstations on wheels, and already making network enhancements. Additional training, a lot of tip sheets that we're sending out to the staff on how to do things, quick tricks, as well as reminders on training. Data, you're starting to collect data. I think as both Renee and Paul had mentioned earlier, that we're going to start getting more data. Dashboards and reports will be coming soon on quality, operations, and financials. And then at the end of this is the transitional service agreement. So we did enter into an agreement with Verity Health Services when we acquired the hospitals for them to support their legacy systems. That ends September 30th. And so we're working with that to end out that agreement as well. So I went very quickly. I'm happy to entertain any questions and turn it over to my colleagues, John and Pat, for any comments.
Supervisor Ellenberg?
This is really impressive. I just want to congratulate you for the work that this was done, and particularly with regard to the report. I thought that the format and this project management approach that you've taken really is a good model. I might suggest that we use the same model or adopt something similar for the staffing integration report. But thank you very much.
Thank you.
Thank you. And Mr. Lorenz, you're the overarching presenter on this item, yes?
I am, yes.
So if in addition to thank you, I had just one word I wanted to make sure that I shared with all three of these folks, can you guess what that might be after the years we've worked together? I'll give you a clue. It starts with P. Privacy. Privacy.
Oh,
I'm really, see, that's why I asked.
I said it.
There you go.
Privacy.
Privacy. Thank you. I know that in the healthcare world, you're all veterans of HIPAA, and that this should be integrated into sort of everything we do. But I always am concerned with a mission-driven organization that other important elements can be overlooked or perhaps not highlighted as much as I think they should be when you're focused on the mission. So your mission is keeping people healthy, saving people's lives, but I just want to make sure that we're mindful of our obligations around privacy and data security as we do that, particularly as we're sort of blending organizational cultures, which we are, particularly as we've got folks who have not been subjected to my privacy pitches over the course of the last 6 years. So I just wanted, bless you, Ms. Carter, just wanted to bring that one to the fore since we're talking about electronic health records today. Thank you.
Absolutely, thank you.
Then, of course, there are other items in the integration report. Do you want to present briefly, or should we just go straight to questions if we have them?
I'm okay with going straight to questions.
Let me just ask, on packet page 101, after saying thank you again for the last report, packet page 101, St. Louis, there's an indication in the graph, this is page 2 of 12, if that's a better reference for some folks. It looks like the payer mix changed appreciably over the course of a year from July to June. I'm looking at the color-coded Medicare line that seems to suggest that we went from around 35, 36% Medicare to 52%. And I'm looking at the line that goes in the other direction on commercial payors, dropping from around 35, 36% down to apparently 13.6%, if I'm reading the chart correctly. And I'm wondering, should I be concerned about the drop in commercial pay? And because that's a pretty significant drop over the course of a year. And what should I make of the appreciable increase in Medicare as a part of the payer mix? Or is all of that neither here nor there for some reason that I can't imagine?
Thank you, Supervisor.
Everybody's smiling, so apparently there's an answer. So
if you look at the date in which that occurred, which was at the time in which we acquired the hospital, part of it is how they're being categorized in terms of financial class. So one of the things that we will be doing is looking at the financial classes going forward and making sure that they're consistent between the legacy system and our current systems.
So did I understand you to just say part of it has to do with what we call different payors? It's a semantic issue?
That's part of it, yes.
Not so much semantics, but the way that Verity, there's Medicare, straight Medicare, there's Medicare Advantage, there's Medicare Medi-Cal, that is called MIC. Yeah, whatever. And Verity categorized those differently. Some of them categorized as commercial, some of them just categorized as Medicare. So for us, we categorize them differently than they do. Our concept of commercial is really just, the big blues and some VHP, but not all. So there is a change. But even if there was a significant drop, it's not a problem for us in terms of finances, and it's also not a problem for us in terms of drawing more patients back, because there has been the instability, which led prior to the sale and, immediately after the sale, doctors to wonder what they should do with their patients. And there was a time period where they were basically funneling them off to Good Sam and Regional. Now, as you heard, there's a whole lot more satisfaction and happiness among the doctors, particularly with the implementation of HealthLink. So I expect the numbers to go back up of privates.
Let me ask for an off-agenda report back on this, because I understood what you were just kind enough to share, but if that were the case, I would have expected then similar lines on O'Connor, and I don't see the same level of increase on Medicare there or the same decrease on commercial. So if it were a function of how we're characterizing certain payment flows, one would think that that would be similar in the two Verity hospitals, and I'm sure there's an answer to that, and I'm looking forward to it in an off-agenda report. The other thing is, if I heard it correctly, let me ask the question a slightly different way. Would staff then say there really hasn't been a significant change in the payer mix at St. Louis in the year that I'm looking at? Or has there been, and if so, what is it?
I would echo actually what was said. We have seen some changes. Many of our private physicians, when we declared bankruptcy, said, well, maybe I'm not going to bring my patients to your bankrupt hospital today. So we did see a migration away of some of those. The volumes, though, haven't changed. So while we saw some commercial patients migrate away, we've seen that filled with demand from Medicare, Medicaid populations.
Does that mean that when I look at the chart a year from now that shows a year subsequent to the year that's in our charts here in the packet, that we're hoping that that number has ticked up on the private pay side, on the commercial pay?
Well, that depends on how good I am.
Okay. I'll take that as a yes. Thank you very much for that.
Yes, it will happen.
Thank you. Then, in the same report, under finance, billing, and collections, packet page 104, page 5 of the 12-page report, figure 5 has the claims. Thank you. This was interesting information. It says figure 5, claims billed, charges, and collections for OCH and SLRH as of July 31, 2019. I may not be asking the question the right way, but starting when, if you know what I mean? In other words, presumably those charges didn't all roll in all at once. They go back to how far again? March 1st. Thank you for that. And then, so when I look at the Medi-Cal charges of 37 million and change, but the collection of 716,000, if I did my math right, I think that means we have collected as of July 31st only 2% of the total bills. And then on the commercial pay, I'm looking at charges of 126 million and change, and a collection of 12 million, which would be 10% more or less. And when I'm looking at the total dollars, Medicare, Medi-Cal, commercial, total as of July 31st, charges $288 million, which I believe is a little more than what we paid for the whole package. Am I remembering that right? Yep. Okay. But we've only collected 33 million, which means that 250 million is yet to be collected. What should I be making of those numbers?
Several kinds of things are, number one, on the Medicaid payments, we have a couple of phenomenons there. At the end of the state's fiscal year, the state tends to withhold payments
I used to be in the state, so I remember that, yeah. Okay.
So, in addition to that, we had some contractual issues with the electronic claim submission company that prevented us from submitting all those claims. And I would say what you see here is probably about half of the charges that we've got so far have been billed. There's another half we're working on right now. We expect to see significant payments in the next few weeks for Medicaid. I think that the other thing that you said is, you know, the fact that we have $288 million of charges here, and we didn't pay that amount for the hospitals. Again, that's the phenomenon in the hospital industry where we have a gross charge and we get paid something less than that. So I think actually considering we've used their system to gather the charges and to do the billing and so forth, that I think we've done fairly well considering we took over on March 1st and you know, now we're moving into Epic, and I expect that Epic, the submission of charges and the billing will be more regular than it was. But we'll have a period where we have to collect the ones that are on the old system. That'll probably take 6 months or so to finish that up.
Could I ask that as we have these reports come back to us, I think we're going to do the integration report now every 2 months for a while, that we have this same chart with the same starting date, updated, because while I understand what you just shared, which was very helpful, I always use my sidewalk office hours test, which is if a constituent walked up to me and said, do I understand correctly that we've collected only 2% of our Medi-Cal buildings since we took over? If the answer to that is yes, they're going to want to know why, and same with the rest of the questions. So I think if we can just keep tracking that, because what I take by way of assurance from you is we will catch up on not all of it, but most of it. Then I'd kind of like to see how much we catch up and how quickly we catch up as a sort of an accountability tool for ourselves.
Yeah, we can do that for
Thank you so much. Supervisor Ellenberg.
Thank you. In the interest of time, I have triaged all of my comments down to one priority request, and this was mentioned as well in part of the background of the waiver report, but I would like to see a progress report on the children's health assessment implementation work come back to HHC in the next couple of months, possibly during an accountability meeting. Can we do that? Great. Thank you very much.
Then without objection, Supervisor, if we can have a motion to receive the report.
So moved.
Motion by Ellenberg, second by Simidian. Without objection, hearing none, so ordered. Thank you again, and I just want to underscore, you were kind to move very quickly through a lot of work, but please know that it was noted and appreciated. And please share that with all who were part of it, which is, I think, virtually everybody in the organization. So thank you again. All right, that takes us to item number 8, which is the update from the director, and we have, of course, a number of verbal reports underneath that, and again, we're going to ask people to go as expeditiously as they possibly can. We do have a card from Mr. Largent. Mr. Largent, this is on 8D, Behavioral Health Services. If you want to come forward now, we'll take care of that, and then we'll just turn directly to our staff.
Thank you. Thank you, Jessica. Suggestion, I think a lot of recovering addicts make good, they just know how to interact with the people that are on the streets. I mean, we all know that. It's a common thing. And I'm concerned, Tony, that the people that were brought out the other day, I just don't think they had it. And I got to watch it and experience it. They didn't know how to interact with this man. There's several people from City Hall that have gotten to know a lot of these addicts around there. And I watch them interact with them, and it's really impressive. They know how to talk to them, find out about their family members. And they call me now, as weird as this sounds, they call me the meth whisperer, because I know how to talk to these people, because I've been sober for 3.5 years. I find out about their families, how long they've been using drugs. I've been doing my own research now, finding about their families, trying to contact them. Just a suggestion, maybe we could start doing that. You know, I don't necessarily need a job. I would volunteer. I would share the information I have. The reason I'm filming down there is to get more details about these people, to find out the ones that have mental health issues and the ones that are smoking meth. Because some of them that say they have mental health issues, I have 20 or 30 videos of them smoking methamphetamines, and I know more information about them. So I just think we need to get a little smarter about this whole thing. I think we could figure some things out, so thank you.
All right, thank you very much. Mr. Santiago.
Yes, Supervisor, we have another 25-page report, but in the interest of time, I'm here to answer any questions.
Ms. Ellenberg.
You're referencing everything that's left from 8A to 8F?
No, we're going to run down the row so that people have an opportunity to put something on the table. So
Okay,
let's
then
do
I'm gonna hold
8A
on.
then. Going to hold off. All right. Ms. Cody? Dr. Cody?
Thank you. Maybe the clerk could put the timer on. I feel a little under the gun. I have my minute and a half. Okay, ready, go. In the interest of time, I'm just going to update you on two items, one around vaping and the other around syphilis. So as you know, yesterday we put out a press release to highlight some results from a new study of middle and high schoolers, and we have new good data on the prevalence of vaping. So about 1 in 3 of our high schoolers are vaping. The reason, what I also wanted to highlight, one is that it's incredibly prevalent and the rate seems to be increasing, but also that they are able, many of them report that they're using flavored products and they're buying it at local stores or they're buying it at vape shops. So we have some opportunities for enforcement. The other part that I wanted to highlight is we always say that we don't know really what the short and long-term harms of vaping are. And right now you may be reading in the news, there are reports of acute lung injury associated with vaping. There's almost 100 cases across the country, 20 of them in California, none yet in Santa Clara County, but it's severe acute lung injury as in people on ventilators from vaping. Very much an active investigation, so I wanted to highlight that. And then I know I did put a little piece in the written report around syphilis, but I wanted to just let you know that since that was written, we've had one additional case of congenital syphilis. And 2 seconds to go, I did it. Thank you.
Thank you very much. Chief Executive Officer, Santa Clara Valley Medical Center.
Supervisor, I have nothing at this point.
We covered a lot of ground. Thank you for that, seriously. And behavioral health, we covered a lot of ground again. Thank you very much. Valley Health Plan.
Thank you. It's a pleasure to be here and to represent VHP. I just want to make 2 comments.
And if there are only going to be 2, we want them into the microphone for sure, so thank you for that.
I don't know how to get it any closer. I'm sorry.
That's okay.
I have to do like this.
There you go.
Hi, Tony. So just a couple of comments. There was some discussion about the financials related to a reduction in commercial collections at St. Louis and O'Connor. I just want to mention that VHP has actively been in the market recruiting the physicians that represent the commercial patients. Paul and his team have done a great job privileging over 800 physicians, and we have now contracted with 100 of those community-based physicians. And I hope to see that those efforts, as they continue, will encourage folks to admit their commercial patients to the hospitals. We'll continue to do that. Certainly, we've found great receptivity at St. Louis, most particularly for contracting with VHP for commercial patients. The second thing I wanted to bring your attention to is we're moving into open enrollment for Covered California. As you know, we've had great success in the past. In open enrollment, we now represent 30% of the Santa Clara marketplace for Covered California behind Kaiser. We are doing many community events in anticipation of Covered California, and I hope you will see some of the work out in the communities that you serve.
Could you remind us, or at least remind me, the open enrollment period runs from when to when?
It's the month of October.
Okay. Thank you.
And that, unless you have any questions about the report that was submitted, I will say thank you again for the opportunity to be here.
Thank you. I know it's been a long meeting. And that takes us then to the federal health policy and budget landscape. And then I want to turn to Ms. Ellenberg to make sure we don't overlook any last questions or comments from her. Mr. Margol.
Yes, I'll be very brief. On the dish cut issue, the House has taken action in the Energy and Commerce Committee to delay those cuts for 2 years. We're still waiting for action by the Senate. That'll be the next shoe to drop in that battle over deferring the dish cuts. In the drug pricing battle, the major event we're awaiting in September is Speaker Pelosi's plan. She's negotiating internally with her caucus. When she puts out her plan in September, that will advance that debate forward. Within the last few days, the Title X gag rule, which relates to abortion services, was which began the implementation process. In response, Planned Parenthood has moved out of the Title X program, and which will reduce access to those services for a large population here in California. The other event that's occurred recently is the public charge rule, which deals with the ability to access Medi-Cal services and also pursue a green card. That's been put out by the Trump administration. Its actual practical effect, number of immigrants impacted by public charge, narrowly defined, may be relatively small at the level of practical impact, but the fear factor in the immigrant community is a much larger issue, and the great concern is that people will drop out of Medi-Cal and not seek those services unnecessarily because of the fear factor. And the last issue is the Fifth Circuit Court of Appeals is still deliberating on the Texas versus U.S. ACA repeal case. We're awaiting that decision, which will, of course, have major implications for the ACA. That completes my report.
Thank you. Ms. Ellenberg, questions, comments? You had one you were going to hold for somebody? Yes, no, or did we get it covered? Got it covered? All right. Then I will say thank you to everyone, particularly those of you who got scrunched at the end. Whether you thought that was a hardship or a benefit, I'll leave to you. Supervisor Ellenberg, that will take us to item number 19, which is to adjourn to our next regularly scheduled meeting of this committee on Wednesday, September 25th at 2 p.m. in these same board chambers. Without objection and hearing none, we stand adjourned. Thank you all very much.